So hello, Assalamu alaikum, everyone. Uh, I guess everyone is ready to go. So we will not wait for anyone else. So we can start right now. So my name is Dr. Farrukh Javeed, and we'll be starting this neurosurgical annual review course from today. And hopefully, over the next 5 days, we will be able to have some concept of the clinical examination, as well as a bit of practice for the main course. I guess you guys can hear my voice clearly. If not, just let me know.
यहाँ से वाईफाई नहीं मिल जाएगा
Can you guys hear me?
No, yalla.
Okay, good. So today is the first day. So we will keep it on the lighter side. So we will start with just the introduction today, and then a few basic thoughts about the examination, clinical examination, and how to attend the exam. And then in the last part of the day, we will have a few cases to discuss. So can you guys see the screen now? So this course was started around 20 years back by Dr. Rashid Jumma, and he was at that time probably in the AQs, and before that he has served in the JPMC Karachi as a professor. So this course has helped a lot of guys in neurosurgery. People like me have also learned a lot from Dr. Juma himself, as well as from these courses. And when I joined him in this course from 2020, I also did a few courses before that, but I wasn't in FCPS at that time. But since 2020, I have been conducting along with him this course probably regularly. Sometimes we face few problems and we go live online. I mean, but we try to have these courses physically, but that is more challenging sometimes to arrange such courses, especially with the restrictions being forced by the CPSP that you have to do such physical courses at least 2 months before the examination. I mean, the real exam. So that's sometimes very difficult to arrange 2 months beforehand because most of people are going through the theory exam at that time, or probably not that much ready to have a course like this. But somehow we can do this online. So at least you guys have. This will be the faculty we'll discuss later. These are a few previous course pictures which we had physically at JPMC, another course. Then we had another course as well at JPMC. And sometime before that, we used to arrange it at AQ as well. So this is how we proceed. And today we will be discussing these topics. And I will be the coordinator over here. And Dr. Ali Afzal will be the next for our presentation. Then we have Dr. Saqib. Probably he is in OR right now because he had some emergency case to do. But we will see if he can come back and join us later. Then we have the Dr. Rabail Akbar. She will present about the TOACS. Dr. Tanweer for short cases. Then I will discuss a bit about the long cases, how to attend them. Then Dr. Asad Abbas will join us for Viva tricks and few tips as well. Then in the last part, we will have a 45 to 1 hour discussion of a few basic cases to start with. So this will be the day for today. And from tomorrow, we will have these topics. So day 2 will be the talks from 10 a.m. to 2 p.m. We will try to maximize the number of talk stations, and we will try to involve as many of you as possible. And others can obviously observe and see uh, the scenarios and the questions and the answer as well. We will try to have a short 2 minutes to 5 minutes discussion or disclosure after each talks cases so that you can have the question straight away, but not more than that. Okay, because we want to maximize the number of stations as well. Then on the day 3, it will be Monday, 29th. It will be a short case day. So we will try to cover all the short cases. There are around 18 to 22 short cases with some different names and headings. So we will try to cover all of them. So one participant will be doing a short case, though it's an online course, but we will still try to give you the maximum experience we can provide. So you will be provided with a short uh, examination findings. For example, if you are asked to do a head examination, so first we will like you to share your knowledge and practical skills, and just tell us that what will be the things or the clinical findings you will look about the head examination cases and also the relevant examination. And then we will give you some positive findings and some negative findings. And on that, we can have a discussion on radiology, on the management. So this will be a short case as we have already for the 10 minutes. So next 5 minutes, we will have disclosure. Kindly आप लोग जो है वो अपने माइक्स को वो साइलेंट पे रखें if possible. अगर किसी को कोई चीज शेयर करनी है तो they can raise the hand and then we can give you the opportunity to talk. And then we will have the long cases on day 4. That will be the Friday, 3rd October. So it will be, I mean, it is like a week from now. Okay? So we are trying to engage the senior examiners for those long cases. I mean, the examiners that we usually face in the rate exam or in CPSP Part 2 exam. So we are trying to engage them. Though we have the limited time, but we will try to cover 5 cases on each day, day 4 and day 5 long cases. So it will be a 30 minutes case and 15 minutes disclosure to have a discussion on that topic, on that case, and also about that particular candidate as well. So this will be like the whole exercise of 5 days. And I guess it will be very much helpful for you guys. I will have to mute you guys. So if anyone wants to add anything, we have 5 minutes to start with. So just any suggestion or anything else you want to just share right now, we can let you talk. And then we will have the Dr. Ali Afzal. He will be presenting the next topic. I mean, the next talk we will give. Anyone who wants to say anything about the course, any suggestion, or especially about the experience you are having. I mean, the video is proper and the presentation you can see easily, and also the voice is audible or not. You can leave the text messages over here as well, I mean, in the chat, but you can also unmute yourself and talk. Or if you're unable to do that, you can just raise your hand and I can unmute you. So, okay, I guess we should. Walaikum
Dr.
Salam.
Farrukh, thank you for the video presentation. You are quite audible clearly, and the video is also present on the screen. Thank you.
Okay, good. So I guess Dr. Ali Afzal is here with us, and Dr. Ali Afzal, I'm just stopping my screen, and then you can. Um, I'm I'm using the okay. I'm using this Zoom for after such a long time, so it is a bit difficult for me as well. But I hope Dr. Ali Afzal can share his presentation now. And Dr. Ali Afzal is in Nottingham right now, and he has done his FCPS from JPMC, Karachi. He was my senior, and he is one of the inspiration for me as well, and many other neurosurgeons from JPMC. He did his FCPS in first attempt.
Assalamualaikum, Farrukh. Good morning, everyone.
And
I
Dr.
hope you can hear
Afzal
me.
has always been available for any kind of educational activity. I mean, you name it, and he will have the data. He will provide you all the stuff for an examination, for research purposes, and for any other educational activities. He used, I mean, Dr. Ali Afzal used to have the session for IMM surgical examination as well. And I also joined him for a few sessions. So, I mean, you can name any examination, particularly in the neurosurgery, and he can help you with that. So he's just that kind of person. So, Dr. Aliusen, and I welcome you, and I hope you can share your screen, and then we
Assalamualaikum, Farrukh.
can
Good morning,
start
everyone.
qualifying
Can
the
you hear
screen.
me, Farrukh?
Yes, sir. I guess
Uh,
everyone else can hear you as well.
I can't share the screen. You have to enable it.
Okay. Now you can say, I guess. I guess you can share now because the settings are right there. Yeah, we can see your screen now. And someone just asked that if they can record. No, you guys cannot record this session because Zoom doesn't let any participant to record this session. I guess so. But the video is going live on YouTube as well. So you will have a recording as well on the YouTube. And also, I will be recording this session uh, so we can provide it to anyone if he or she wants. So, Dr. Alipson, you can start, and meanwhile, I can check that if we are
Sure.
doing live. Yes,
Thank you again, Farrukh, for your kind words. Good morning, everyone. Assalamualaikum. My topic is actually a month preparation for the exam, and I don't think it's a 30-minute long talk. I don't want to bore you guys and make you fall asleep, but I'll try to do my best. Uh, Congratulations to everyone who's passed. Uh, 30 days is a good time. I think you have more time. The exam's on 6 November. Too much time, I don't think, is a good thing because you will start losing the knowledge you gained in theory. But now you have to put that knowledge to the test. So, the most important thing for any exam or any, I think, thing you want to do in life, you have to believe in yourself and that you can overcome any obstacle. And of course, you have examples of people before you, people like us who were in a similar state, and we passed, so you can also pass. Okay. People who are giving it again, uh, it's a shame you couldn't do it the first time, but don't lose hope. It's a fairly standardized test now compared to things you'll hear about a few decades ago. They've tried to make it quite a fair exam, but things do happen on that day that are beyond our control. Sometimes it's luck, sometimes it's just not picking up on the signs or the hints. So I think the most important thing for me to say is, and this is what I said to I think every junior of mine, you have to take the exam seriously. This is an exam that you will be doing yourself in person. No one else can do it for you. And in that exam, You're expected to talk and behave like a consultant. And of course, you are expecting to leave as a consultant. It's not going to be easy, but it's not an impossible task. As long as you know what to deliver and how to deliver it, uh, you should have a good chance of succeeding. A lot of people like me, we also made a few mistakes on the exam. That's part of the preparation and the stress that you go through. But as long as you're doing all the correct things and making the correct impression, you will have a good chance to succeed. So the day you walk in and the day at the time you walk out of the exam, you'll be a different person, regardless of the outcome. And you're expected to become a consultant, a day one junior consultant, and your knowledge and your interaction with the patient should reflect that. So it's a good time. This is the most important, I think, 1 month of your life, because this is the most important exam of your life. If you want to pursue neurosurgery, then you have to dedicate this time. I can help you with some advice. I can't tailor it for individual people. It's always different for different people. We're in different stages of our life with marriage, family issues, and of course, on-call stresses and personal stuff. But you have now to focus on the exam because this is the most important exam of your life. This will define you and give you the status of a neurosurgeon. So believe me, Pakistan is the quickest place where you can become a neurosurgeon. It's not that easy anywhere else. But you have to take the exam seriously. You have to put aside everything else and focus on the exam. You have to be selfish enough now to give it everything you have so that you pass it. And once you pass it, you don't have to do anything else. Fellowships, even if you do them, you're not expected to take exams for every fellowship that you do. And after this, you're just building on your experience and, of course, the good habits or the bad habits that you've picked up during your residence. So, the first important thing I think for any exam is that you need to understand what the exam itself is, what you're expected to go through, and these mock exams and courses or even online presentations that you have on YouTube now will guide you as to what to expect, how things are happening. So, it's a 2 day clinical exam. The first day is task oriented assessment or TOACS, 15 stations. You get about 6 minutes, and then there's a break. There's some rest stations. It's like talks you give for IMM, but only this time it's specialty oriented. Topics can be variable, but there are a few topics I think so. I will try not to speak too much about content because I think we've got talks to cover it. And then the second day, basically, you have to get talks out of your mind.
Uh,
What's done is done, and then you go
Sorry,
on to
Dr.
the
Ali
short.
Afzal.
Yeah.
Dr. Ali, I don't know if you are scrolling through your slides or not, because the slide is stuck on the very first slide, the presentation is there.
Can you see it now?
I guess you have to maximize it. Now, yeah, it's moving now. Previously it was not,
No,
and
I
you
think
can
with
make so
maximum, I
much.
think with maximum it's not working. I think.
No, it will.
Can you see it now?
Okay, just you carry on. I mean, it's not going to full screen, but yes.
Okay. So it's a 2 day exam. Second day is long case and short case. Uh, the exam will tire you out day one and day two, and the timing of the long and short cases will vary. So you might end up waiting to do the long case by midday and then quickly move on to the short case, or sometimes you'll probably give the long case very early and have the short cases at the end. So it's keeping you cool and timing yourself, preparing for it, and in the end of the day, it's just going through the motions and Uh, you think it's going to be a long day, but it gets over very quickly. You have to get out of your comfort zone. CPSP, there's a dedicated area where the exams happen. It's like any other examination room. It will have a patient bed, space for the examiners, space for you to put your stuff in. You will be facing 15 to 20 totally different examiners. You might face one examiner more than once in talks or short, long case, but you'll at least have totally new people. You can't face an examiner, it's all time. So this is the thing that people lose their cool on. You have to practice, make sure that you're on time. So if it's like 5 minutes, you have to prepare for 4 minutes, 50 seconds. Uh, just have enough time to switch like you have to do between short cases. And there's a dedicated time for Viva part of it. So you have to finish on time. Uh, if you don't finish on time, then it's very unlikely that you'll get your long case passed. It's every man for himself, as I said. You have to now be selfish enough to focus on the exam. If you think you're good, it's going to take the first attempt to get the orientation of it, to see what happens, and probably we'll see. So I think that's not the correct attitude. The first attempt is the time you have the full confidence and the maximum chance of passing. Uh, People who end up going into cycles, they somehow it takes more than 2 or 3 attempts to pass as well. So I would say give it the best shot you have. You have to ignore all wives' tales. There's a lots of myths going around. The exam will test you. People who have not done well previously, no one tells you the truth what happened in the exam, and somehow because you're in that stress, you don't realize the mistakes you're making. If you have ever sat in the audience and watched someone prepare or give an oral presentation or present a long case, you'll see the mistake that person is making that you yourself would not be aware of. But in the audience, you'll pick up on the little clues or the things that the person is not doing right. The examiners will try to give you a hint. They're not going to be indifferent, but there'll be some obvious blunders that they can't ignore. You might end up hearing that people were failed because they couldn't take the blood pressure properly or something else, but that's all BS because the main issue is that you have to get the diagnosis correct and then you have to select an appropriate management plan. That's what the exam is about. Your professionalism will also count. You have to approach the patient, introduce yourself, approach from the right side, take the patient consent. In the end, when you've done a particular exam, you have to make sure that if you've lifted the clothes up, you have to pull the clothes back down, use a dressing to cover the appropriate parts of the patient. All these are very important. If you're doing it, that's why the 30-day is very important. You have to practice daily now. I'll give you a plan, as I said, but these are things that you have to forget what old people are saying because this exam is about you. Other people's experiences can be relatable, but it's not an absolute. So, preparation, practice, and eventually this will build up your self belief and confidence. If you go totally unprepared, then you're depending on luck. Luck will help you, but it won't get you as far as half the exam. You can't expect to pass all of the exam on luck without having the knowledge. As I said, if you have a good time before the clinical, then it might, make you lose some of the edge that you had because of the knowledge that you built up in theory. So you can relax a bit, but not too much. And preparation practice will help. Without that, there's no chance. No one in the world can pass an exam without that. I'll be touching on a few things. I'll not touch too much because I think Saqib, a dear friend of mine, will be touching on the exam day itself. So I'll try to just focus on study and travel and a bit
Dr. Ali,
about what the
you can go and talk about the exam day as well because Dr. Saqib is busy in two
show.
emergency cases. He's
Yeah,
in London right now, so I don't know how long he will be there in the OR. So you can
okay,
talk about the exam day as well. We
sure.
can have him if he is available later on.
Yeah, I'll just cover the basic. I think that should be enough for exam day as well. So planning is key. You have the date of the exam, so secure your leaves now. Study leaves or annual leaves, whatever you have. As I said, this is the most important exam. You need the last 10 to 14 days off work. You can keep going to the hospital because you need to keep interacting with the patients, but This is the time that you have to get your act together. Even if you're going on calls, and I hope that you're now senior on calls, not doing 1 in 3 independent calls. So you can use that time very, very
Really,
efficiently.
Afzal?
Even if you're going on calls, I hope that you're now senior on
Really?
calls. So as a senior, you just have to guide your juniors. You don't have to see every case yourself or do all the operations. So you can use that time to see new patients, practice your short cases, just go randomly into wards and select a adult patient or pediatric patient and time yourself. If there's someone else in the same department that you're friends with, I had Asad with me, and it really helped. The most important thing I think you can do is start teaching others, because you have to present, you have to speak orally, you have to develop your confidence in describing radiology, describing your poster findings. So start teaching juniors. Even if I think if you're going to theaters, it's a good time. Common cases will be common. If you're doing a CP angle tumor, you can put up the radiology while the patient's being put to sleep, or you've done the team brief, and you can take your consultant or your juniors through the radiology itself, what possible differentials, what's your approach going to be, how will you position the patient. So this is important. Uh, People who try to stay at home and try to think that they can get through the exam without interacting with patients, without going to OR or having the steps, nailed down. I think that's very foolhardy. It's probably wishful thinking, but that's not going to happen. And most sometimes when you're stuck in the exam, it's your experience, your knowledge of a patient, a particular operation that you did, a particular patient you saw, and the management plan and the things that you did wrong that will come back and probably guide you to the correct answers. So don't stay home. Whoever tells you to stay home, that's bad advice, totally bad advice. This is a clinical exam. You're expected to interact with patients, you're expected to present. So staying home is not the option. Even if you're the best speaker, the best debater in your school, uh, you have to get your act together. Uh, Another good thing is that that's what I used to stress with my juniors, Farrukh and Rabail and others as well. That that's what you're expected to do when you're in the exam or when you have done the exam. If a patient comes to you, you have to give them a proper management plan. So your planning is important. Start it now. They'll expect you in the end when you've discussed everything, radiology, everything that. So what will you do now? So what will help you make that plan? If it's a trauma patient, you've got ICH score, you've got other things. If you need to diagnose a patient, you've got criteria like NF1, NF2. So start using them now. It will become a reflex by the time you do the exam. Last and most important is knowing your strength and weaknesses. Uh, you know your knowledge is good, your presentation is weak. Start working on that. You're expected to speak in English. For some reason, I don't think this will change. You need to practice English. Make sure that you are loud, you're clear, and you're speaking the right words. Okay. You can confuse he and she, but as long as you're saying the right thing, that's okay. As I said, the examiners will allow you a certain degree of freedom, but not too much. It's very important now to make your travel plans. You know the center now. You have to reach there in time. You have to be there on time. The examiners will expect you to reach very early. As soon as you reach the center at 8:30, all the examiners will come and meet all the examinees. They'll greet you and then tell you what your group is, if you are going straight ahead or you're waiting to start. CPSP does have limited seats available, so if you need to travel to Karachi, it's a good idea now to call CPSP, arrange for that lodging to be there, because if you're in PSP, then you don't have to commute from one part of the city to the other. Again, Karachi is a busy city. Even if you have been to Karachi, uh, like I've been to Islamabad, I've not seen all the hospitals. So it's a good idea that you reach there early. You find out where the main hospitals are because the cases will be coming from there, and you're staying in a place close enough and that you can reach the examination hall in time. Avoid last minute delays or panics. Don't rely on reaching the city one day before. You never know, the plane, the flight gets cancelled, the plane takes off, but there's an emergency, it lands again. And, the stress of not being able to reach, I think that will be a shame if that happens. Again, different provinces have different language. In Karachi, you'll probably will get away with speaking Urdu. People do understand Punjabi as well. Sindhi is one of the main languages, but a lot of people will understand Urdu. But if there's a communication barrier, then you can ask for help. But if you don't do that, then you're probably stuck. Uh, so that will affect your history taking. Appropriate clothing and print. So you need to be dressed smart. You don't have to dress fully heavy in coats, three-piece suits, but it should be appropriate, should be clean. Probably a good shirt and tie. You should have your own lab coat. You should have your own equipment. Now is the time to, finally buy things if you don't have them. Take that one day off from a schedule. Go and get all the stuff that you need. You're expected to have your own fundoscope. If someone can give it, lend it to you for the exam, that's good. Otherwise, you need to buy it now. Believe me that in short cases and in the long case, you'll be expected to use the fundoscope. Watch videos, go to the eye department, learn how to use the ophthalmoscope. The examiners will expect you to use it. Okay, so you need to have your equipment. And a tip that we were given to help deal with kids is, get some small toys or keychains with lights in them so you can give it to the child and distract it. Because I remember in one of the short cases, the child was already crying, and the examiner told me that the baby should not cry. And then I was looking at the examiner thinking, it's already crying, so what can I do? But anyway, so there are a few tips that you can do. You can ask the mother to put, if they usually have a bottle of milk, they can give it that to the kid. If you need to examine the MMC for say, then you can ask the mother to put the child on her shoulder, because that way the face will be away from you, and you can focus on the back and start with your main examination. So there are tips to getting around it, but these are things you learn only if you've interacted with patients before, and you don't have to panic, and just stress tests basically. Okay. Uh, so you have to understand the study format. I'm just about to share two files in the main group so everyone can have a look. So it's basically about the different topics that you're expected to have. So one is target NS talks, and second is the protocol of examination. So I've shared it in the group so everyone can have a look later. It's just an idea of what to expect. These are the common topics that were asked previously in the exam. This is what you expected to know, and these are things that you should know. Okay. So the division of topics I provided, what to expect and what is expected of you. So as I said, you need to know how the exam will be distributed, uh, what are the timings of different stations, and this is a thing that happens throughout the world. So you need recalls. I do have, I think, two recalls in that NS Stokes topic that I've shared. But you can always, find out from your seniors or people who have passed exam what the topics they encountered. More or less, it's the same topics, but of course, the scenario is different, the radiology is different. But of course, there's a finite number of topics that can be asked. It's very important now to set up a daily routine. You should have a timetable. If you have a calendar, you can use that calendar. And of course, present daily. If you don't present daily, then you're in for a hard time. Making a timetable, of course, so you have a number of days that are left before the exam. What are the topics that you need to cover? Uh, and have some time at the end for last minute revision. I prepared with my dear friend Asad. We basically split topics according to themes. We had a vascular theme, infection, tumors, brain separate, spine separate, then pediatrics. We all know, hydrocephalus is common, TB is common, brain tumors. Then you should have a section, trauma, basically all the spine fractures with the classifications, TBI management, indications for decompressive surgery, cranioplasty. So all these are things that you need to know. I have, I think, put them in that file that I have shared. So make a realistic plan, things that you need to deliver on. And as I said, you have to get rid of every other activity, focus just on the exam, and take some time out for, breaks for your family. But focus should remain on the exam. So it's time to up your game. You've got 2 long cases to do every day at least, 2 to 4 short cases. And of course, now is the time, if you haven't done it so far, pick up the atlases, pick up the operative textbooks, have the skull spinal models in front of you. You will be expected to hold the skull or the spine, tell us the important landmarks that you can see, craniometric points that are on the first few pages of Greenberg. You need to know where the motor cortex is from the coronal suture. What are the 3 different sutures that are used as a landmark to put your CP angle burr hole? What is the McCarthy key point? Uh, and of course, in the end, radiology and radiopedia. So if you have MRI, put it up, look at the report, see how it's being reported. You don't have to remember per se that it's a good thing if you do know, but it's not the end of the world if you don't know which tumors are hyperintense or hypointense. It's a good thing to know. And of course, CT, the terminology is density. In MRI, it's intensity. And in X-rays, it's radiolucent, radiopaque. Okay, so these are things that you don't have to waste time or you're expected to be very fluent in it. Radiopedia is amazing. It's got all the things called the relevant X-rays and MRIs and everything else that you need to know. It's a good idea to go through them as well, just for practice sake. And basically, as I said, uh, the more practice you gain, the more better you'll become. So in the end, I think if you've done 50, 60 long cases, you've done about 80 to 100 short case examinations, you've done all the necessary maths, then of course you will come out a winner. This is something that cannot be stressed enough. If you don't work on this, then you're leaving things to chance. And as I said, don't follow any advice that says, just give it and see how it is, and then, we can do it the next time. That's not how it happens. You have to understand what you're weak on, what you're good on. Okay. When you start, of course, when you all started, you can never do this in 30 minutes. But if you keep practicing, then eventually you can finish the long case in 30 minutes or even less. So history taking is 8 to 10 minutes, examination 16 to 18 minutes. So that in the end, because they'll ask to, okay, present your long case, uh, and you'll start presenting it, and they'll start cutting you short as well. No one will ask you about demographics or, personal history unless it's relevant. They'll ask you to, okay, so what are your differentials? What are your positive findings from the examination? So unless you're writing them down side by side, it's a good thing that you can present without looking much on the paper. You'll have a paper, you have a pencil as well to write. But the less you look on it, the more you present, the better impression it gives. If you have one examiner by your side, then at least you're secure in half of the way. The first impression will count. So this is the thing. I think if you can get it down, history to 8 to 9 minutes, examination to 16, 18 minutes, and 2 minutes to summarize. That I think is ideal. You can take the full 30 minutes. It's not the end of the world. You'll be stressed. But I think if you have done it enough times, then you should be, easy. They will give you a 5-minute warning before the end that 25 minutes are up. And at that point, I think you should be nearing the end of your examination. So this will take practice. Uh, and remember that once you hear the presenting complaints, you should have a differential in your mind and then focus on that. If you think it's a post fossa, then asking every detail about frontal lobe or temporal lobe or memory is not important. You just have to ask a few questions and then focus straight away on the area of interest. If you think it's a skull base meningioma, then you focus on the sella or the skull base. Uh, you do ask all the other questions, but they just skip through them, most of them. So this will take practice. That is what I said. You need to now 2 long cases daily, 2 to 4 short cases daily. Take time out to look up the operative approach and radiology. Okay. Short cases, of course, need to be very, very quick because you have to move between the stations as well. And somehow the 5 minutes include your movement from one station to the other. You should have your kit ready. You should know where things are. So you don't have to keep, searching for your inchy tape or your tendon hammer or your needles. Okay. And of course, introduce yourself, tell the patient what to expect, and start. Don't waste time. You don't have time. You're expected to get done in 5 minutes, and then they'll start the Viva bit of it. The more time you take, uh, the less time you'll have for the Viva, and they can't get you through enough answers to give you a passing mark. Okay. So in the end, this is there's a finite number of cases. I think, given the presentation that Farrukh has lined up for you, I think you will probably have an idea of the most, and I've tried to summarize them for you in the document that I've shared. Recent advances is a question that you're asked right in the end. So with every topic, if you're making some notes or sticky notes, you can just put in some recent advances on management. Okay. Uh, if it's a good thing if you know all the trials. If you don't, then that's okay. But it's a good thing that if you do have no major trials in trauma, vascular, and current trends in the world, the more practice sessions you take, the best. I think even here people have made, because of WhatsApp and everything else, you've got online study groups. So you have the topics divided out, and you got a good number of people, and you take turns. So it builds up your confidence to present, and then everyone discusses good and the wrong. So at this time, I think you should take all the criticism positively in the course as well. Don't think someone is targeting you. Uh, once I think you realize, once you've done the exam, you realize, your mistakes you made, but luckily, they weren't significant enough to fail you. But sometimes that can happen as well. So focus on the positives. No matter how good or bad your talks goes, I think, like every other person, you'll try to calculate number of stations that went well and what your score would be, but you need to put it behind. Focus on the next day. It's a fresh day. It's all about short and long cases now. So very, very focused now on what to expect. Uh, so I think if you've done your prep, your confidence is good, you know, you should have a very good chance, I think, and all these courses will definitely help you. But the patient is the most important person now that you need to interact with on a daily basis. Don't leave it to chance. Don't leave it to luck. Uh, give it your best. Inshallah, most of you will succeed. Sometimes a lot of people succeed. We had, I think, unbelievable number of people passing our attempt or the attempt next to us. So don't think they have fixed number of people they need to pass. If you are up to it, you will clear the exam. Okay, there's no doubt about it. they can't fail you without reason. Don't think it's an unfair exam. If you think that a particular examiner is not favorable, you can report it. You can ask a different examiner to take his place. Okay, and that's your right. In the end, this is a good online tool if you don't know about it. Victor Notes. This is a very, very good selection of topics. It is very exhaustive. You don't need to go through all of it. But if you think you need to know a bit more about recent trials or some other stuff, then it has got some very, very good points or highlights. And as I said, these are notes. You can quickly go through a topic in 5 to 10 minutes. You can download the PDFs for free. So this is a good tool. You do have time now. I wouldn't recommend it for the last week, but given that you do have time now, I think it's probably a good thing to go through. In the end, good luck, all the best. You can do it, and I think we're all on the group now. So if you want any help or any input, you can always contact me. I think even the other people like Farrukh, Rabail, Tanweer, and Asad, they are very, very approachable. And if you need anything, any help for the exam, any guidance, even after the exam for fellowships or getting out of Pakistan, then we'll be more than helpful. Glad to help you out. Okay, you're all colleagues now, and start thinking that you're a consultant. You can start practicing in front of the mirror, but don't gloat. Don't think. You can probably see a consultant neurosurgeon, but you have to go through the process, and inshallah, you'll make it. Thank you.
Okay. Thank you so much, Dr. Ali Asad. And it must be so early in the nothing.
Yeah, it's
But I guess
yeah.
Again, we should appreciate your effort and thank you so much. And we would like to have you for the case discussion as well.
Yeah, I'll be
of the
there.
meeting.
Yeah.
And thank you so much.
If anyone has any questions,
Anyone
otherwise I'll take a break.
wants to have a question, a very short, discussion on anything related to exam day or before the examination. You guys have more than a month now, and it is a good enough time to prepare yourself, even if you have a lot of weaknesses, or even if you were sleeping earlier. But now again, you can wake up properly, and you can pull up your pants and just get ready for the exam. So you guys can leave the texts in the chat as well, and Dr. Ali, me, and Tanweer, Rabail, we guys can answer your question as well. So next, we would like to have Dr. Rabail Akbar, and she is assistant professor right now at JPMC Karachi, and she did her FCPS exam in I guess 2021. I hope I'm right. And she also cleared her exam in the first attempt. And she has been coordinating these sessions, especially the physical ones, very regularly. So she knows very well about the weaknesses of the candidates going into the exam. So she will be talking about the TOACS today. So over to you, Dr. Rabail.
Can you hear me?
Yeah, we can hear you.
Okay, thank you. Thank you, Dr. Farrukh, for introducing me. Assalamu alaikum, everyone. I'm Dr. Rabail Akbar. Today I'll be talking about tips and tricks for TOACS. And before we start that, I just want...
Sorry, Rabail, अगर थोड़ा सा और अगर आप loudly बात कर सकें तो बहुत ही great.
Can you hear me now?
Because the recording session में बाद में problem होती है थोड़ी सी voice का, तो इसलिए I want it should be clear now. Yeah.
Okay. Can you hear me better now? Is it loud enough?
Yeah, you can continue now.
Okay, so first of all, I just want to say it was a great talk by Dr. Ali, and he has helped most of the JPMC candidates and others as well throughout for the exam preparation for the last few years. And so whatever he said, I want everybody else. I would advise everyone to take it like as a constructive approach. Can you hear me? Because there's some interference.
No, don't worry. I will be making them new it again. Okay. You
अच्छा, तो
continue.
डॉक्टर अली ने हमारी बहुत हेल्प की थी, तो whatever he said that helped us a lot through our whole examination process. And I would also advise everybody else कि जो भी आपके seniors है, आपके जो भी आपके hospital में ward में, you should all go to them and you should take their advice because it helps a lot. It helps a lot during examination. So coming back to TOACS in my opinion is strictly my opinion, but I feel that TOACS is much more important in preparation for than short cases or long cases. The reason for that is that TOACS is your first ever interaction with the examiners, right? So you imagine that you're going into this big, large room and you enter that room, and inside that room there are multiple examiners, a lot of big names that you've heard throughout your neurosurgery training, and this is your first interaction with them. So it is daunting. A lot of people, they lose their cool, they lose their nerves, and then you go to the station and in front of you is a professor that you've heard so many things about. In front of you is examiner who you heard so many things about, and right, all of a sudden he's asking you these questions, and before you have time to compose yourself and answer whatever they're saying, before you have time to carry compose yourself, pick up your nerves and say anything, uh, you know, it's just 5 minutes of talks, right? So 5 minutes per station, 5 to 7 minutes, and these 5 minutes become so daunting that sometimes you, even though things that you've known before, that you've prepared for before, sometimes they just don't get out of your mouth the way you want them to. And then your 5 minutes are up all of a sudden, and then you go to the next station, and before you have time to breathe and pick yourself up, the other examiner comes in front of you. So it is an onslaught, it's a vicious cycle. And a lot of people, they're still reeling from what they've done in the last stations, that they're still thinking about, it's on their mind that मेरा ये station था, ये बुरा हो गया, I could have said this and this, कि वो आगे वाले station के बारे में इतना नहीं सोचते. This is a very important part, because then it accumulates, and throughout your whole exam of TOACS, you have this thing that ये station खराब हो गया, 4 खराब हो गए, 5 खराब हो गए, I'm not going to pass this. And you carry with this throughout the exam, and then next is short cases and long cases. If you manage to pass TOACS and you go for short cases and long cases, you still have that trauma from the first day, because you were not well prepared to face the examiners and face the stations the way that you have. And it's very important, because जब हमने अपना first course किया था NRC का before the exam, I remember at the end of the exam we went to Dr. Juma and we just said, we wish कि आपने जो है course था. It was, I think, 10 days before the exam at that time, and we asked and we told him कि like काश आप एक month पहले कर लेते, because we didn't know our drawbacks. हमें ये नहीं पता था कि हमने क्या क्या mistakes की, and वो exam में वो during the talk session it came forward कि हमने ज्यादा बोल दिया, कम बोल दिया, 5 minutes से पता ही नहीं चले कैसे खत्म हो गए. And we wished कि like वो, especially the way that we were presenting ourselves, कि क्या बोलना है, कितना बोलना है, कब बोलना है, कब stop करना है, next क्या बोलना है, we didn't know that. And then we were just short of time before going for our first exam. So since this this mock session is being conducted 1 month before the actual exam, it is a very good time for you to make a plan how you're going to approach talks and how you're going to present yourself in front of the examiner, because remember, you only have 5 to 7 minutes, and in 5 minutes you have to give your point forward, you have to answer the questions, you have to give proper presentation. And सबसे important चीज ये होती है कि you should know when to stop and what to say. This is important, because if you say the wrong thing, then the examiner will deviate from the actual questions of the stations, and then वो examiner जो है ना उन चीजों में फंसा देता है, and जो marks हैं वो questions के, the questions that are in front of you are the only ones that are carrying marks. वो जो extra questions होते हैं, they're just for the examiner to assess how you are. So don't deviate. Always see कि सामने station कौन सा है, and then respond accordingly. Okay, so in talks we have 15 to 17 stations. Sometimes they have rest stations in between. If you have rest stations, that is good, because then you have time to compose yourselves. But most of the times there are no rest stations. So we have 15 to 17 stations in total. And it is important to understand that you have only 5 minutes to convey your message. And in these 5 minutes, the first 1 minute is very important, because that is a minute that you're going to read the scenario that is in front of you. So you go to the examiner will tell you, read the scenario. And a lot of people, because वो उस time पे they're like, I only have 5 minutes, I only have 5 minutes, so I have to like do this in 10 seconds. They don't carefully read the scenario, and that is the first mistake that you make. You have to read the scenario carefully, and you have to look for specific buzzwords, like, for example, trauma, fever, sudden morning headache. And these things are important because they give you a clue as to what is going to happen. So the examiner knows that he's only giving you 5 minutes to come to a diagnosis and to answer questions properly. Obviously, they're not going to give you, riddles and stuff. The scenario is going to give you the answer itself. So, for example, if the patient has fever, you quickly jump to, if this is fever, this is probably a case of infection. If there's a word of sudden, then you go towards vascular. If this is morning headache, this is probably a brain tumor, right? So you have to look for these certain terms, these certain buzzwords, which are very important, right? And then you also have to look for other important clues, like, for example, the age of the patient. So if a patient is young, if it is a pediatric patient, if he's like 10 years old, he's 8 years old, 6 years old, then you know what kind of diseases fall into that category. And obviously duration as well. If it is like less than 3 months of duration, this can be metastasis, it can be, some acute infection, and it can also be vascular. So you have to look for these small things and you have to pick up on them. So take 1 minute, in my opinion, read the scenario at least 2 to 3 times if you can, very carefully. Don't take too much time, but when you read the scenario, you know what the station is going to be about. You have a pretty good idea. So that is a good start. And then don't give a diagnosis. Don't read the scenario and you're like tuberculosis. The examiner might not even ask you what the diagnosis is. So wait for the examiner to ask the question. Like, if you're done with the scenario, tell the examiner, yes, sir, I'm done reading it. And then you wait for the examiner to ask his questions, because remember, we don't have time to waste on things that are not part of the questions, right? So what usually happens is, we all know that what usually happens is that, so the examiner will ask you a few questions, and then he might put a radiological investigation, like, we had a case of TB, so the examiner first asked us about TB, the treatment options, second line treatment, third line treatment, and then he put up a radiological. It was an X-ray, I think, an X-ray in which we could see the spots disease of the thoracic spine. So you have to keep time for that as well. And then he asked, "What is the management now? Tell me the management now." So just be precise with your answers. Be very, very precise. Just answer what the examiner is asking. And if you don't know the answer, just say, "Sir, I don't know." Okay, so just move on, because you need to get to the next question in time. And important, just describe the radiology and don't give the diagnosis unless you ask for it. If you're asked to give the diagnosis, like, look at it and tell me what the diagnosis is, only then you give the diagnosis. Otherwise, just describe it. And the description of radiology is not the same as the description of radiology in long case, because in long case you have a lot of time. And in my opinion, in a long case, when you describe the radiology, that is where you score the more points. The best way to score points is in areas in which others are not that good in talking. So, but in talks, you don't really have that much time. So keep it concise, keep it, to the point. Don't go here and there and just describe the radiology that is in front of you. Okay, so these are the common topics that we usually get in the talks. More or less, these are the same topics. So we have counseling, we have logbook, we have instruments, we have neoplasms of the brain and spine. We can have trauma of the brain and spine, degenerative spine, pediatric cases, infections, vascular cases. And then again, we might have some craniometric markings and some recent advances in some functional stations, and neurocritical care and ICU, as well as peripheral nerves. So in 90% of the times, these are the stations that you're going to have. Because they have divided the stations according to their protocols, this is how the stations are being divided. So you need to be very, very prepared about these stations. Don't leave any important topics, because they might come in front of you. And I know some people have this thing where they say that, even if let's not study this part. Even if a station comes, it's just one station. So that is not a good way of preparing for talks. Talks, you should be prepared for everything. And remember, in talks, they're going to give you those scenarios which they cannot put up in short cases and long cases, right? So vascular, pediatric patients, pediatric cases, most of the cases that they cannot give you in short and long cases, they will come in talks. So you need to be prepared for that. Let's talk about counseling first. So the common counseling topics are high-grade lesions with poor prognosis, They can ask you about counseling for brain death, for any post-op complication, pituitary tumors, pediatric patients, and pregnant patients. So usually the examiner is the one that you're counseling, and they're actually seeing how you're approaching the patient, and how compassionate you are, how conscious you are of the patient's feelings or the attendant's feelings while you're giving them this information. And obviously they're going to throw in a few tricky questions in between, and you need to be prepared for that too. For example, in one during my talks, they kept asking us, like, there was a case with a spinal tumor. It was an intramedullary spinal tumor, and in the end, the examiner was asking everybody, what is one most important thing that all of you are, none of you are telling me about that you need to counsel this patient for. So since I was working in a government setup, I had no idea at that time, but he was talking about the cost of the surgery, right? So he was like, obviously you have to counsel the patient that this is how much it's going to cost him. So because I was from a government institute and we did not really have this type of practice when we're counseling patients, most of us missed this part, right? So you have to be very, have to be very conscious about what they're asking, what they want to know. And even if the examiner, the patient attendant who is pretending to be the person that you're counseling, you don't have to lose your cool. Don't lose your cool. Be very, gentle with the patient. That's what they're trying to see. They're trying to see your approach to the patient, basically. Okay, the second would be logbook. So in our time, we had, logbook, we had ophthalmology, we had other things as well. So luckily, you guys don't have that. You have only neuromedicine and you have neurosurgery. So the common topics that they will ask, it can be anything, but mostly it is trauma. So it's not something that is very difficult, but but you need to look into the types of complications that can happen in that certain situation. For example, they can ask you for management of complications such as brain swelling, air embolism, sinus bleeds, any major arterial bleeds. So you need to prepare for that. And also they might ask you any commonly used procedure. So I remember our seniors used to tell us that, in logbook, don't mention any complicated big procedures. Because then you might get stuck. But if you're well prepared for it, I don't think there's any issue in mentioning those procedures if you actually seen them in the logbook. If you think you can handle the questions, then you can put whatever there is inside it. But in my experience, they did open the logbook, they did select topic, and then they asked me about it. Right. So anything in the logbook is fair game for them. And obviously, you also have to talk about the management of post-op complications. So seizures, hematoma, neurological deficit. Common questions, nothing too confusing or nothing too complicated. The third would be there will be an instrument. Most of the times, like 95% of the times, there's an instrument present over there, or like an endoscope, an aneurysm clips, cardiac catheters, shunts, spinal implants, cervical tractions, MIS. So usually there's something always present. So be prepared. Be prepared. Take the instruments that are present in your hospital, look at them, go through them. So spinal implants are very important. All of the instruments that we use during the spinal fixation, they can come in this station. So you have to go to your ORs, you have to take those instruments out and, involve the senior and learn about them if you don't know already. These are important. And also endoscope, because they also ask you to, disassemble and assemble the endoscope. And they ask you which ports go where. So they actually want to see if you actually if you held an endoscope during your surgery residency. So you can get this from just videos. Take the endoscope in your ORs, try to assemble and disassemble them, because these things usually come in the exam. They came in our talks as well. Okay, so neoplastic is very important. Meningioma, CP-angle tumors, pituitary adenoma, glioma, any tumor can come, because these tumors are the ones that they cannot, again, put up in short cases and long cases. So they can give anything here, anything. So you have to be very prepared for the neoplastic part of the neurosurgical course, brain and spine both. Spine is fairly simple when it comes to neoplasms, so meningiomas, any nerve sheath tumors, intramedullary lesion, arachnoid cysts, spinal mets. Trauma is important. They usually have like 1 to 2 cases of trauma of brain and then 1 to 2 of spine. We had like total 4 stations of trauma during our talks. And because trauma is so wide, it doesn't really matter if you, for example, if you have a subdural hematoma, it's not necessary that they will ask you about the mechanism of the subdural hematoma or the management of it. Sometimes, they can just ask you, they have a subdural hematoma, but they can go directly to neurocritical care for it, right? So what are the steps that you will do after you manage this patient? So from the moment the patient arrives to you in trauma till the patient gets discharged, anything in between they can ask in these stations. The compressive craniectomy is very important because usually there's a whole station dedicated to it. So go through it, read the trials, read the recent advances, read the statistics, because that is what they ask the most. And then again, EVD and ICP monitoring. So ICP monitoring, even without trauma, they usually have a separate station of it. They will ask you about waves. They will ask you about the different waves and obviously the instrument as well, normal and abnormal both. In my opinion, the cervical spine, sorry, not the cervical spine, the spinal trauma is one of the most important stations that they give in TOACS. So, because why is it important? Because obviously they can assess from this multiple things. Like they can ask you regarding the radiology, they can ask you regarding the fixation, the management. So this is a very important station. Spine trauma, I think before, just before to the point. Sorry, I can't hear you. Is anybody talking? Okay, so we usually get in the talks. So we have counseling, we have logbook, we have instrument. Hello? We have classes to the brain and spine. Degenerative spine, pediatric cases. And then again, we might have some craniometric markers. Can you hear me? Some recent advances, some functional. Hello? Can you hear me? So in 90% of the times, these are the stations that you're going to have. Because they have divided the stations according to their protocols. This is how the stations are being divided. So you need to be okay. So cervical fractures. I'm hearing interference, so that is why I'm not able to talk properly. I can hear my voice like I don't know if anybody else is hearing it. When they say that even if let's not study. Okay, so let's talk about the trauma of the spine. Again, I said this is a very important topic. We had, I think, 2 stations, and when there was a model of a thoracic spine, and they were asking us about craniometric points for screw insertions. So there were, and then we had another station in which there were locked facets and other things as well. So trauma spine is very important. I would advise everybody that 1 or 2 days before your talks, go through the whole spinal trauma part. Go through all of it because it is very important. Like most likely get like 2 stations for this. So those are solid marks. So go through those. And in cervical fractures, they can give you odontoid, Jefferson Hangman, subaxial fractures, locked facets. These are very important. And then in dorsolumbar fractures, you have stable and unstable fractures and their classifications. But mostly in my opinion, what they give is mostly they give cervical fractures, and then in thoracic fractures, they will most likely ask you to, mark the point of entry of the screws in the trajectory. Another important one is cervical traction. So spine trauma, very important for TOACS. And then let's go back to degenerative spine. Degenerative spine is important. What they usually do is they focus more on radiology. So in degenerative spine, you can have prolapsed disc, you can OPLL, stenosis, kyphoscoliosis, spondylolisthesis. Any of these stations can come. So I would advise you to make small notes for TOACS, make small notes, because you can say too much. You don't have time. You don't have time to say too much. So make small notes like for prolapse disc. What are the different options, surgical options? What are the minimally invasive options? What are the open options for stenosis, for OPLL? So that will help you a lot, because then you can say, सोचने का time इतना नहीं होता, you can list everything. So you need to say these things in points, like open, close, classify things so they are more simple and they're easier for the examiner to understand. And then pediatric. Pediatric is very important. MMC, tethered cord, carry malformations, encephalocele, anything can come. And these are pretty, they're pretty simple topics. And most of these things are, these are the patients that you've seen very commonly during a neurosurgical practice. So these should be on the tips of your fingers. And because obviously MMC sometimes mostly comes in the short cases, they will focus on tethered cord. They will focus more on, diastomitomalia and the MRIs and radiology. So go through all of that. Radiology is very, very important in all cases in TOACS. It's very important. And then in carry malformation, they might ask you about the different theories of the way the carry has developed, as well as different surgical approaches according to different surgical theories out there as well. So that's what they asked me. That's why I'm sharing it with you. So carry malformation has a very high chance in any TOACS of coming. And then hydrocephalus, so including shunt complications and ETV success score. Another favorite topic of the examiners, arachnoid cysts, craniosynostosis, joint skull fractures. In craniosynostosis, because so craniosynostosis is not, in my opinion, in Greenberg, it is written quite adequately, but there's certain things that are not present over there. So I would advise everybody to go through certain other pediatric books in which it is much better mentioned, the surgical options that you have, because obviously they're not going to ask you to describe the surgery, but they will ask you to name different surgical processes for this. So we have open approaches, we have close approaches. So I would advise everybody to at least see pictures of it or go through it, because it is also one of the most commonly asked station in TOACS. And then we have infections, we have brain abscess, we have TB versus fungal. TB is very important. TB usually does come in TOACS. We had TB spine, but they can also give you any tuberculoma, meningitis, anything related to that. So it's important, go through all the treatment options that you have, the medical treatment, the first line therapy, the second line therapy, the third line therapy. I do remember the examiner asked me for fourth line therapy as well. I did not know it at the time, but then later on I read about it. So go through that as well. And then we have subdural lymphomas, meningitis, hydrated, all common topics. And then in spine, discitis is important, Pott's disease is very important, and the management of these and how they look up on the radiology. So go through the radiology, very important. And in vascular, so in my opinion, what they usually like to keep in vascular is radiology, CT angiograms, and a lot of people, CT angiograms, cerebral angiograms, they don't really know how to read that. So I think before going into TOACS, you should master these. At least you should be able to read what's there, because this is what they do. They give you the radiology and then they ask you, what do you think this is? And if you cannot even go past that, if you give the wrong diagnosis, then they might not give you the marks for the next questions, because it's important. The questions are related to the radiology most of the times. Right? So for example, if I had an AVM and they were asking me point out where the venous drainage is, point out where the arterial drainage is, and in which vein or in which artery it is draining to, all of that. So they were asking me, they asked about anatomy a lot. So master the radiology is very important. Most of the candidates, they don't know about that. So radiology for vascular is very important. Trials are important. And I have heard that in a few exams previously, they did ask about DAVF as well. So the uncommon topics should also be touched. And craniometric marking, they will usually put a skull or a spine model in front of you, and they will ask you about landmarks for surgery, for example, for pterional approach, for subfrontal approach, for retrosigmoid approaches, where the asterion is, where the pterion is, where do you put the keeper hole. So most of the institutes, they have a skull in their library, or some senior might have it. So take the skull and practice all of these things on it, and also take spine models as well. That is important. And then sometimes they also ask you to mark on the skull where is the ventricular entry points for shunt insertions. So Keynes point, Coccus points, all of these points they might ask you to mark on the skull. Very commonly they do that. And spinal level marking, this is important because they will ask you like preoperatively, how do you mark through landmarks, through anatomical landmarks, how do you mark through radiological techniques, and how do you mark intraoperatively. So go through that as well. In recent advances, we have neuronavigation, tractography, stereotaxy with types and differences. They have come in previous TOACS stations, ETV, endoscopy, spine, and in recent advances, they can basically ask about anything. They can ask you about 5-ALA, they can ask you about other advances that are being performed in foreign countries as well. So I would advise for the common things, especially for like brain surgeries and spine surgeries, type in on Google spinal recent advances and brain recent advances and see what they're doing outside. Because a lot of the examiners, they do go outside, they take these courses and they come back and they expect people to know. Functional and peripheral nerves. So these are two important topics that are not very commonly encountered in our practice, right? So these are actually weak points. What I would suggest for all of you to do is for peripheral nerves and for functional, I would ask you to right now, because you're 1 month, make this your priority at least for a week, because a lot of people are weak in this. They don't have a first-hand experience of these procedures or these patients and different interventions that we do in these cases. So since they don't have it, they're usually very weak when it comes to Viva. So there's a good book for functional. I would recommend Schmidig, and for peripheral nerves, I would also recommend Schmidig, because the chapters in that book are very, very good for these two topics. They're extensive. For example, DBS chapter is very good. It is very well written in the book, but it is kind of extensive. So what you can do among yourself, if you're a group of friends, you can ask one person to read it up, make a small presentation, and then he can convey to the others as well to save time. As compared, it would be much easier than all of everybody going through it at the same time and wasting a week on it. So it's much better if one person can make a small short presentation, or maybe one of the seniors might have it. Seniors usually do have these presentations, and you go through it together. And then if there's anything of confusion, you can go to your seniors, you can ask them for help or guidance in this. So
Dr. Rabail, we are running short of time. So
okay, just 1 minute. Just 1 minute more.
Okay.
So peripheral nerves, carpal tunnel syndrome, wrist drop, thoracic outlet syndrome, these are very common and important topics. Brachial plexus injuries, they will ask you about presynaptic, postsynaptic, so go through that as well. And CSEMGs, they might also come in exam, especially for carpal tunnel syndrome. And then we have neurocritical care, and this is where a lot of people do get stuck. So they will ask about renal care, cardiac care in a patient on a ventilator with head trauma, PET source, how do you manage that? How do you manage the urine output? That's what they asked us. So that's why I'm saying that don't just look into the superficial aspect of it, like STH, trauma, surgery. Also go through the neurocritical care, because one station per session is almost always present. So the reasons of failure is this again, not controlling your nerves, not really understanding what to say, when to say, how to say it. And obviously you have the previous station on your mind all the time. And so these are important things. If you're done with the station, you're done with it. Don't think about it, don't go back to it. Just continue with the next stations, because if your one station goes wrong, and it will go wrong, nobody's 100%, right? So that doesn't really matter. Just focus on the next station. Okay, so thank you everyone. Thank you. Does anybody have any questions?
Okay, thank you so much, Dr. Rabail. And we can have 1 minute question answer session. If someone wants to ask any question about the TOACS. TOACS is one of the important things, because you guys know very well that without clearing the TOACS, you cannot attend the short and long cases now. So it is kind of a one step at a time thing. So you need to clear the TOACS, clear out your concepts today, And tomorrow we will have the TOACS cases. But if you have any query, you can talk today. And some people are asking about the books. So I guess Dr. Rabail can help you guys. She's also on the WhatsApp group, so she can I mean, link you to some books regarding functional and critical care as well. So I guess we do not have any question right now. So then, अच्छा एक तो चीजें और हैं वो ये कि I mean more than 50 people registered and you filled their forms for this course, and more than 40 people actually paid for it. So I am still seeing 35 people. I understand that people are busy in the morning time, but I would just say simply पहले के मैंने text में भी कहा, but ये कि इस वक्त your most important thing is your exam. ठीक है? So focus on your exam, and these talks might look a bit boring to you, but I mean, trust me, ये सबसे important चीज है. Even जो है आप exact जो जाके प्रैक्टिस भी कर रहे हैं टॉक्स की, ये शॉर्ट केसेस के, लॉन्ग केसेस के ऑन पेशेंट, उससे भी ज्यादा इंपॉर्टेंट ये टॉक्स हैं, बिकॉज these talks will help you clear your mistakes. वहाँ पे आप मिस्टेक्स कर रहे होते हैं एंड बहुत लिमिटेड टाइम के अंदर आपको आइडिया नहीं हो रहा होता कि आप कौन सी मिस्टेक्स किए जा रहे हैं, एंड एंड ऑफ द डे यू जस्ट फेल इट. सो बेहतर ये कि आप यहाँ पे इन जो तो थोड़ी सी टॉक्स हैं, बिल्कुल बेसिक कॉन्सेप्ट जो है वो आपको समझाए हैं, ताकि जो टॉपिक्स हैं उनको ईज आउट करने की कोशिश की है कि आपको एज अ ग्रुप जो है वो उस टॉपिक को लेना है. फॉर एग्जांपल जैसे राबेल ने भी इतने सारे हमारी जो हेडिंग्स थी वो डिस्कस कर ली कि फंक्शनल है या नहीं प्लास्टिक है, तो उसको एज अ ग्रुप आप लें. ठीक है, आप उनको ये नहीं कह सकते कि अलग अलग करके क्या मैं जो मैं एक दिन करूंगा और ग्लैम और दूसरे दिन करूंगा. ठीक है, पढ़ने के हद तक वो सही है, यू हैव ऑलरेडी रेड दोस टॉपिक्स, बट नाउ आपको उनको एज अ ग्रुप लेकर चलना है और एज अ ग्रुप आप उनको प्रिपेयर करें. जब इन्फेक्शन की बात करें तो यू शुड हैव ऑल द इन्फेक्शन इन माइंड व्हेन यू आर मेकिंग योर डिफरेंशियल्स. So this is how you have to attempt the exam. और तो बस यही चीज़ है. So we will discuss further. And next we have Dr. Tanweer Ahmed, and he is assistant professor at JPMC right now, and he also passed his FCPS exam in his first attempt. He's also from JPMC, and he also has been actively coordinating these sessions, online sessions as well as the physical sessions. So he has the idea of the weaknesses of different candidates, especially the ones who repeatedly fail such exams. So I hope he is gonna help you with this short cases now. So Dr. Tanweer, you can share your screen now. I would just suggest everyone to keep your cameras on. इसका हरगिज़ ये मतलब नहीं कि no one is wants to, I mean, किसी और मकसद के लिए नहीं, बस मकसद ये है कि you guys should be attentive enough to have this session, because from tomorrow on, if your camera is off, we will not take you live. ठीक है, because there is some attitude, you need to have that attitude to be ready for the exam. अगर आप फेस नहीं करना चाहते, if you are not daring enough, if you are not confident enough, फिर आपको एग्जाम भी मुश्किल हो जाएगी. So that is my suggestion to everyone. ठीक है, आज कोई इतना जरूरी नहीं है आप कैमरा ना ऑन करें, बट फ्रॉम टुमारो व्हेन वी हैव द इंटरेक्टिव सेशन, आई वुड सजेस्ट कि आप अपना कैमरा, स्पेशली द वंस हु आर टॉकिंग, द वंस हु आर अटेम्प्टिंग एनी सिनेरियो, दे मस्ट हैव देयर कैमरास ऑन. ठीक है, सो थोड़ा सा 4-5 दिन की प्रैक्टिस है, बट इट विल हेल्प यू इन द रियल एग्जाम. ओके, ओवर टू यू डॉक्टर तनवीर.
Assalamu alaikum. Thank you, Dr. for your nice words. फर्स्ट ऑफ ऑल मैं डॉक्टर अली के बारे में कहना चाहूँगा कि जब हमने एग्जाम की तैयारी की थी तो डॉक्टर अली वाज देयर एंड डॉक्टर फरूख वाज देयर. दे हेल्प्ड अस अ लॉट इन क्लियरिंग आवर एग्जाम. और मैं तो ये समझता हूँ कि शायद इनका बहुत बड़ा रोल था हमारे एग्जाम को क्लियर करवाने में. हमारे यूजुअली हम लोग उनके साथ बैठते थे, सेशन डिस्कस करते थे. सर उस टाइम भी इंग्लैंड होते थे, वहाँ से हमारे साथ इन्वॉल्व होते थे सब चीज़ों में. मेरी आवाज़ आ रही है ना डॉक्टर फरूख?
Yes, आवाज आ रही है Dr. Tanweer, but I guess you should start your presentation, because we very well know about Dr. Ali Afzal, and he will be back with us for the discussion as well. And तब हम बात कर सकते हैं इस बारे में, because we are running short of time and we have to give mic to Dr. Asad as well, because he is also busy. So we need to take him on time.
ओके, सो मैं बस थोड़ा सा ब्रीफली चीज़ों के बारे में डिस्कस करूंगा। जब हम शॉर्ट केस की बात करते हैं कि शॉर्ट केसेस ऑलमोस्ट सबको ही पता होता है, हमने एक लिस्ट बनाई थी, वी हैव टू मेड अ लिस्ट, और सबके पास वो लिस्ट ऑलरेडी होगी कि कौन कौन से शॉर्ट केसेस होते हैं। तो अगर जब हम लिस्ट बनाते हैं तो मेरा थोड़ा सा पॉइंट ये है कि आप इसको लिस्ट को इस तरह से कंपाइल कर रहे हैं शॉर्ट केस की कि आपको पता होना चाहिए कि कुछ शॉर्ट केस ऐसे होते हैं जिसमें ऑब्वियस डायग्नोसिस होता है। जैसे से फॉर एग्जांपल आपके पास कोई पेशेंट हाइड्रोसेफ्लस का आ जाता है, या कोई स्पाइनल डिसऑर्डर है जिसकी आपको कमांड होती है कि एग्जामिन द स्वेलिंग ओवर बैक, या एग्जामिन द हेड, या क्रेनियोसाइनोस्टोसिस। ये कुछ ऐसे केसेस होते हैं जो बिल्कुल ऑब्वियस होते हैं ना, जिसमें आपको सामने ही पता चल जाता है कि डायग्नोसिस मेरा ये है, बस आपने उसको फॉलो करना होता है। इसी तरह से कुछ शॉर्ट केसेस ऐसे होते हैं जिसमें हमें बहुत ज्यादा प्रैक्टिस की नीड होती है, क्योंकि वो लंबे होते हैं, आपके पास पता है कि टाइम बहुत कम होता है, हमने 5 मिनट्स के अंदर ही सारा एग्जामिनेशन कंप्लीट करना होता है। या से फॉर एग्जाम्पल कुछ केसेस ऐसे होते हैं जो हम बहुत रेयरली करते हैं, जैसे प्रोप्टोसिस हो गया, या इसी तरह से सेंसरी एग्जामिनेशन, मोटर एग्जामिनेशन। ये हमारी डेली रूटीन में बहुत ज्यादा हम इसको प्रैक्टिस नहीं करते। तो इस तरह के केसेस जिसमें आपको ज्यादा प्रैक्टिस चाहिए, आप उसकी एक अलग से लिस्ट बना लें, जिसको आप बार बार उसको आपको रिपीट करना है। ओके, इसी तरह से फिर आपको ये भी पता होना चाहिए कि मतलब कि जो भी शॉर्ट केस होगा उसके अंदर रेलिवेंट एग्जामिनेशन कौन सा होता है। बहुत सारी दफा हमें पता ही नहीं होता, हम एक केस कर रहे होते हैं लेकिन हमें रेलिवेंट एग्जामिनेशन के बारे में आइडिया ही नहीं होता कि हमने किस तरह से उसको लेके चलना चीजों को ना, और उसी तरह से रेलिवेंट क्वेश्चंस। तो अभी आप लोगों के पास टाइम है, आप लोग ग्रुप्स बना सकते हैं, ग्रुप्स बना के आप उसमें सारी की सारी चीजें रख सकते हैं। आपके पास एक छोटा हर एक शॉर्ट केस की क्यूरीज हो, आपने आपको पता हो कि ये वाला अगर केस है शॉर्ट केस, तो उसमें मुझे ये रेलिवेंट क्वेश्चंस पूछने हैं। तो ये सारी चीजें आप जो है इसको कंपाइल कर सकते हैं। ओके, इसके अलावा एक बहुत इंपॉर्टेंट चीज व्हिच वी सी दैट वी मोस्ट ऑफ द टाइम मिस इट, दैट कि हमारे पास एग्जामिनेशन किट ऑर्गेनाइज नहीं होती। बहुत दफा ऐसा होता है कि हम लोग जब प्रैक्टिस कर रहे होते हैं तो हम अपने एक ही कलीग की किट यूज कर रहे होते हैं, उसी से वो प्रैक्टिस कर रहा होता है। तो मेरे ख्याल में ये एक बहुत बड़ा मिस है, क्योंकि जब एग्जाम का टाइम आता है, जब हम वहां पे जा रहे थे, हमें पता ही था हमारी कौन सी चीज कहाँ पड़ी हुई है। तो आप अभी से अपनी मतलब एग्जामिनेशन किट लें, उसको ऑर्गेनाइज करें प्रॉपरली, आपको पता हो कौन सा इंस्ट्रूमेंट कहाँ पे पड़ा, और हमेशा कोशिश करिए उसको वहीं पे रखें। क्योंकि जब आप इसको इतनी दफा प्रैक्टिस कर लेंगे, जब आप एग्जाम में जाएंगे तो एग्जाम के अंदर भी ये चीजें आपको बहुत हेल्प आउट करती हैं। बहुत दफा हम लोग देख रहे थे कि एग्जाम में जब जाते हैं, काफी दफा मुझे काफी दफा जाना भी होता है, जब भी कराची में खास पे एग्जाम होता है वहाँ पे, तो जो स्टूडेंट्स होते हैं वो ढूंढ रहे होते हैं चीजों को, किसी को टॉर्च नहीं मिल रही होती उस टाइम पे, आपके पास सिर्फ छोटा थोड़ा सा टाइम होता है 5 मिनट का, तो तब वहां पे चीजें हमें मिल ही नहीं होती। तो आप अभी से ये प्रैक्टिस करें। से फॉर एग्जाम्पल जैसे टॉर्च है, अगर किसी को ये है कि आपने उसको पॉकेट में रखना है, तो आप अभी से उसकी हैबिट बना लें, ताकि जब आप एग्जामिनेशन में उस टाइम जाएं, आपके पास थोड़ा सा टाइम, आपको पता हो कि आपका कौन सा इंस्ट्रूमेंट कहाँ पर पड़ा हो। ओके, सो अगर हम बेसिक्स की बात करते हैं शॉर्ट केसेस के अंदर, तो हमें मतलब 4 शॉर्ट केसेस होते हैं, सबको पता है उसके बेसिक कंपोनेंट जो होते हैं। तो हाँ, इसमें बहुत इंपॉर्टेंट चीज है कि जो आपके कंपोनेंट है शॉर्ट केस में वो क्या क्या होते हैं। सबसे पहले तो ऑब्वियसली आप जाके ग्रीटिंग्स करते हैं, कंसेंट लेते हैं पेशेंट से, पेशेंट के कंसेंट लेने के बाद क्या करते हैं, एक्सपोयर करते हैं। एक्सपोयर के बाद सॉरी, ग्रीटिंग, इंट्रोडक्शन देते हैं, फिर कंसर्न, एक्सपोयर, और उसके बाद फिर क्या था, आपको एक कमांड दी जाती है स्पेसिफिक एग्जामिनेशन की। अच्छा, एक चीज मैं इसमें ऐड करूंगा कि काफी लोग क्या करते हैं कि हम लोगों को जब कमांड मिलती है, हम एक मशीनिक वे में स्टार्ट कर देते जाके, कि भाई बस एक कमांड मिली है, आप एग्जामिनर को लग रहा होता है कि बस ये सारी चीजें वो फॉर्मेलिटी। मेरा एक मतलब कहने का माइंड ये है कि जब आप किसी भी शॉर्ट केस को लेते हैं, तो आपके माइंड में चीजें रैम्बल्ड होनी चाहिए हर एक केस के लिए। जस्ट मैं आपको एक सिनेरियो देता हूँ, से फॉर एग्जांपल कि आपको एक कमांड देते हैं कि आप एग्जामिन करें अपर 6 क्रेनियल। जैसे ही आपको ये कमांड मिलती है, आपके माइंड में फौरन चीजें आ जानी चाहिए कि मुझे अगर अपर 6 क्रेनियल दी गई है, तो ये पेशेंट जो है इसमें डायग्नोसिस क्या हो सकता है। मे बी ऑल्फैक्टरी ग्रुप मेनिंजियोमा। अगर आप से फॉर एग्जांपल जब फर्स्ट ट्रेनिंग आप देखते हैं, उसमें आपको थोड़ा सा हिंट मिल जाता है, पेशेंट को जो है वो स्मेल परसीव नहीं कर पाता, तो आप उसमें आपके जहन में साथ साथ डायग्नोसिस चलने चाहिए। से फॉर एग्जांपल आपको फर्स्ट केस में क्या क्या चीजें जहन में आ सकती हैं, कि पिट्यूटरी का केस हो सकता है, या फिर क्लिनोइडल मेनिंजियोमा हो सकता है, क्रेनियोफेरेंजियोमा हो सकता है, ऑप्टिक ग्लायोमा हो सकता है, या फिर ट्राइजेमिनल न्यूरैल्जिया, या इस तरह की चीज हो सकती है। ठीक है, इससे हटके कोई भी चीज नहीं होगी। तो आप जैसे ही एग्जामिनेशन स्टार्ट करते हैं, सारी की सारी चीजें साथ साथ आपके जहन में चलनी चाहिए। आप जब फर्स्ट नर्व को कर रहे हैं, आपके ध्यान में आना चाहिए कि ओके फर्स्ट नर्व के पास ये चीजें हैं, तो हो सकता है कि ये हो। ओके, सेकेंड नर्व आपने जब एग्जामिनेशन स्टार्ट किया तो उसमें भी सेम इसी तरह से है कि आपके ध्यान में आना चाहिए क्योंकि पिट्यूटरी हो सकता है, अगर पेशेंट की फील्ड जो है सही तरह से नहीं मिल रही या पेशेंट की जो विजुअल एक्टिविटी नहीं है, तो हर एक चीज आपके ध्यान में साथ साथ शॉर्ट केस के चलनी चाहिए, क्योंकि आपको पास 5 मिनट होते हैं जिसमें आपने एग्जामिनर को इम्प्रेस करना है। ओके, उसके बाद स्पेसिफिक एग्जामिनेशन की बात पे क्या होता है, आपको रेलिवेंट एग्जामिनेशन। बहुत दफा ये होता है कि हम लोग एक फ्लो में जा रहे होते हैं, हमें याद ही नहीं रहता कि हम क्या करें, एग्जामिनर से पूछें भी कि रेलिवेंट एग्जामिनेशन हम खुद ही स्टार्ट कर देते हैं। तो एग्जामिनर हर चीज नोट कर रहा होता है और इसे ये चीज अनाय भी करती है। तो प्लीज आप जब भी आपका एक स्पेसिफिक कमांड कंप्लीट होगी, जब आपको रेलिवेंट एग्जामिनेशन के लिए जाना है, तो आप लाजमी उसके लिए परमिशन लें एग्जामिनर से, पूछे कि अगर आप मुझे इजाजत दें तो मैं। अच्छा, काफी दफा ऐसा होता है कि जो पेशेंट ऐसा होता है कॉपरेट नहीं कर रहा है, चीजें नहीं होती, तो आपको एग्जामिनर खुद ही मना कर देता है कि बस ठीक है छोड़ दें आप। लेकिन आपने जो भी इसके सारे के सारी चीजें हैं, जो बेसिक्स कंपोनेंट है, वो सारे कंप्लीट जरूर करने हैं। ओके, फिर इम्पोर्टेंट रेलिवेंट एग्जामिनेशन जो है, उसके अलावा फिर आपने लास्ट में क्या करना है कि कवर लाजमी करना है पेशेंट को। काफी दफा ये होता है कि जैसे ही हमारा एग्जामिनेशन कंप्लीट होता है, हम इतना एंजाइटी में होते हैं, वैसे ही छोड़ के आते हैं, तो एग्जामिनर हर चीज नोट कर रहा होता है। आपको आखिर में पेशेंट को थैंक्स भी जरूर कहना है। इसी तरह से काफी दफा जब शॉर्ट केस में हमारे पास क्या होता है, बच्चे आ जाते हैं, कुछ इस तरह से होता है, वो क्राई कर रहे होते हैं, तो आपने उसका ख्याल करना है। ये नहीं कि बच्चा रो रहा है और आप बस अपनी चीजें कंप्लीट करने में लगे हैं कि मेरे पास टाइम कम है, नहीं, आप एग्जामिनर को बता दें कि सर बच्चा ट्राई कर रहा है, या मैं मतलब प्रॉपर चीज। ऐसा कुछ पेशेंट पेन में होते हैं, अगर आप देखें आपकी किसी भी कोई ऐसी कमांड दी हुई जिससे आपके करने से पेशेंट को पेन हो रहा है, आप तो बिल्कुल से जेंटल रहें और उसके साथ एग्जामिनर को ऑन बोर्ड रखें कि देखें मैं ये चीज कर रहा हूँ, लेकिन मुझे पेशेंट जो है आगे से पेशेंट को ये इशू हो रहा है, तो ये सारी चीजें आपने देखें। और अच्छा, इसमें एक बहुत इंपॉर्टेंट चीज होती है रिस्पेक्ट ऑफ एग्जामिनर, कि आपको जो भी है जैसा भी है आपकी चीजें, लेकिन आपके दिल में एक एग्जामिनर की रिस्पेक्ट जरूर होनी चाहिए। तो ये सारे के सारे बेसिक्स हैं जो आपको पता होना चाहिए जब आप शॉर्ट केस करते हैं। और आई नो कि आप लोग को ऑलरेडी इसके बारे में सबको आइडिया होगा वैसे। ओके, हाँ, रेलिवेंट क्वेश्चन बहुत इंपॉर्टेंट है। तो आप अभी से ही हर जो भी जितने भी शॉर्ट केसेस की लिस्ट जो मैं आगे आपको दिखाऊंगा, तो आपको पता होना चाहिए कि जो भी केस है उसमें रेलिवेंट क्वेश्चन कौन सा है। क्योंकि एग्जामिनर्स बहुत दफा पूछते हैं चीजें और वो कहते हैं कि आप इस केस से रेलिवेंटली कौन से सवाल पूछेंगे, तो आपका वो क्वेश्चन वाकई इतना रेलिवेंट हो जिससे आपको फायदा भी हो, आपने एग्जामिनेशन में कोई ऐसी चीज मिस की हो जिससे आप क्वेश्चन के जरिए कवर कर सकते, तो आप इस तरह से क्वेश्चन। ओके, सो किट का बता दिया आपको, आपके पास किट होनी चाहिए। सो दिस इज अ लिस्ट ऑफ द शॉर्ट केसेस के हमारे पास तकरीबन, अगर हम देखें कंपाइल करें तो अप्रोक्सीमेटली 20 तक के केसेस हैं, या 16-17, या इसमें कुछ ऐसा ज्यादा मिस हो कि जो आपको जिसकी प्रैक्टिस करनी है। हायर मेंटल फंक्शन है, सेरिबेलम, अपर लोअर 6 नर्व्स हैं, हैंड एग्जामिनेशन है, फुट एग्जामिनेशन, और इसके बाद अपर लिम एंड लोअर लिम एग्जामिनेशन है। ये सारे एक एक करके हम लोग थोड़ा सा जल्दी से इसको डिस्कस कर लेंगे। ओके, सो एग्जामिनेशन ऑफ हायर मेंटल फंक्शन, मुझे मुझे ये स्टेशन थोड़ा सा लगता है क्योंकि बहुत सारे लोगों की इसकी प्रैक्टिस नहीं होती, तो इसके लिए जो है थोड़ा सा आपको ये वाला जो अगर शॉर्ट केस आया था, आपको इसकी ज्यादा से ज्यादा प्रैक्टिस करनी होगी, क्योंकि हम लोग नॉर्मल जो अपने जो ट्रेनिंग टाइम में या इस टाइम में बहुत कम इससे गो थ्रू होते हैं। तो इसमें भी अगेन वही है कि आपको जो शुरू में हमने बेसिक पढ़ा था कि ग्रीटिंग्स है, इंट्रोडक्शन, देन परमिशन, फिर प्रॉपर एक्सपोजर। अब इसमें क्या क्या चीजें आती हैं, पेशेंट का कॉन्शियस लेवल है, जनरल अपीयरेंस है, मूड, बिहेवियर, ओरिएंटेशन, रीजनिंग, परसेप्शन, और इसके साथ ही फिर आपके लोब फॉक साइंस आ जाते हैं। इसमें प्राइटल में आपको कैलकुलेशन है, लेफ्ट राइट ओरिएंटेशन है, फिंगर एग्नोसिया, स्टीरियोग्नोसिस, कॉम्बिंग हेयर, ड्रेसिंग, एप्रेक्सिया। फिर टेम्पोरल लोब में हम लोग मोस्टली मेमोरी देखते हैं, विजुअल एग्नोसिया देखते हैं। इसी तरह से स्पीच आ जाती है, स्पीच के अंदर आपको फ्लुएंसी, एफेसिया, अंडरस्टैंडिंग, रिपीटिशन, रीडिंग, राइटिंग, ये सारी चीजें देखनी है। और लास्ट में फिर क्या कहता है, रेलिवेंट एग्जामिनेशन है, आपने इसका करना है। ओके, रेलिवेंट एग्जामिनेशन में मोस्टली हमने क्या करना होता है कि लोब साइन के साथ में जो है इसमें हमारे पास साथ में कौन सा जो है चीजें आ जाती हैं कि हम मोटर चीजें देख सकते हैं, और लास्ट में क्वेश्चंस होते हैं। आप क्वेश्चन जो है इसमें रेलिवेंट में पूछने पेशेंट को, सीरियस की हिस्ट्री तो नहीं है, क्योंकि मोस्टली आप जब हायर मेंटल फंक्शन आते हैं तो आपको लोग की चीजों को ही देखना है, और लास्ट में कवर एप्लोय। ओके, फिर सेकंड हमारे पास आता है एग्जामिनेशन ऑफ सेरिबेलम। अगर हम सेरिबेलम को एग्जामिनेशन करते हैं तो इसका पैटर्न आप, अच्छा एक चीज मैं और इसमें ऐड करूंगा कि आप जब भी कोई भी से फॉर एग्जांपल जैसे हमने तो यहाँ पे एक चीज मेंशन कर दी, एक फॉर्मेट बता दिया, लेकिन आप जब भी शॉर्ट केस की प्रैक्टिस करें तो आप कोशिश करें आप अपना एक फॉर्मेट बनाएं, आप उसी फॉर्मेट से सारी की सारी चीजें करें और उसको जैसे से फॉर एग्जांपल हमने एक लिस्ट बनाई है, इसमें 15 या 20 शॉर्ट केसेस हैं, आप कोशिश करें ग्रुप बनाएं, जो भी आपके साथ स्टूडेंट्स हैं जो आपके कंपेटेबल हैं, जिसके साथ आपकी अच्छी अंडरस्टैंडिंग है, आप 2-2 3 3 का ग्रुप बनाएं और आप डेली कोशिश करें 4-4 5-5 शॉर्ट केसेस की प्रैक्टिस करें। 5 मिनट लगते हैं उसमें, यह है कि 2 केस देखने की है, दूसरा ऑब्जर्व कर रहे हैं, 2 केस देखने की है, फिर पहले वाला उसको ऑब्जर्व करें, लेकिन आप अपना एक पैटर्न बनाएं, आप उसी पैटर्न को फॉलो करें और उस पैटर्न को लिख लें अपने पास या बना लें। जब हम लोग तैयारी कर रहे थे तो हम लोगों ने यही किया था कि हम 4-5 लोग थे, हमने अपने डिवाइड कर लिए थे शॉर्ट केसेस कि 4 केसेस आप बना के लाएं, 4 आप बना के लाएं, 4 आप बना के लाएं, और उसके बाद फिर क्या किया कि उसी पैटर्न को फॉलो करते थे। जब भी उस केस की प्रैक्टिस होती थी तो इससे ये होगा कि आपकी कोई चीज मिस नहीं होगी, और सेकेंडली आपकी एक चीजें बिल्कुल ऑर्गेनाइज वे में जाएंगी। ऐसा नहीं है कि आप सिर्फ मतलब जैसे सैरी बैलम है, अब सैरी बैलम के अंदर आप क्या करें, हेड नोटिंग कर रहे हैं और हेड नोटिंग के बाद फिर आप टोन पे चले गए, और उसके बाद फिर टोन के बाद आप जो है सिर्फ फॉर एग्जाम्पल हील शिट पे चले गए, रोम्बक कर रहे हैं। तो एग्जामिनर आपकी हर चीज को नोट कर रहा होता है, वो देख रहा होता है कि आप जो चीज कर रहे हैं वो वाकई आप इतने स्किल्ड हैं और आपने अपनी ट्रेनिंग या रेजिडेंसी में इसको इतनी दफा किया हुआ है कि आपकी चीजें बिल्कुल स्किल्ड और ऑर्गेनाइज हैं, या आप हैphazardly कर रहे हैं, कभी किसी तरफ एक ऊपर जंप कर रहे हैं फिर नीचे आ रहे हैं, तो इस तरह से लाओ बस। जैसे अब इसमें देखें हम लोगों ने जो है हेड नोडिंग सबसे ऊपर से स्टार्ट करते हैं, हेड नोडिंग आ गई, फिर आप आईज में आ जाएं तो वहां पे आपने निस्टेगमस और डिप्लोपिया देख लिया, फिर उसके बाद फिंगर नोज टेस्ट आ गया, डिस्टाइडोकाइनोसिस आ गया, स्पीच देख ली, फिर हैंड ट्रेमर्स आ गए, रिबाउंड आ गई, ट्रंकल एटेक्सिया है, टोन है, पेडल पेडुलर नी जैक है, हील शिन है, गेट है, रोमबर्ग है, और लास्ट में आपने वॉक करवा ली। अच्छा, जब हम रेलिवेंट एग्जामिनेशन की बात करते हैं तो सेरिबेलम लाइज इन द पोस्टीरियर फोसा, तो आपको बाकी जितने भी चीजें हैं पोस्टीरियर फोसा की उसको देखना होगा, जैसे से फॉर एग्जांपल आपको फंडोस्कोपी करनी है क्योंकि फोर्थ वेंट्रिकल है, इसी तरह से लोअर 6 cranial nerves हैं, आपको उसको देखना होगा, तो ये सारी चीजें आ जाती हैं। अच्छा, क्वेश्चंस में आपको इसमें जैसे, अच्छा हाँ यहाँ पे हमने कुछ क्वेश्चंस लिखे हैं लेकिन लाजमी नहीं कि सारे क्वेश्चन सेम ऐसे ही हैं। आप अपने सीनियर से डिस्कस कर सकते हैं, जो है चीजें आपके सिनेरियो के हिसाब से वहाँ पे आपको क्वेश्चन, अगर कोई आपने देखा कि एग्जामिनेशन में कोई चीज मिस कर दी, आप उसके हिसाब से उस चीज को पूछ सकते हैं। तो इसमें विजन है, नोजिया वोमिटिंग या गेट के बारे में पूछा जा सकता है, बाकी लास्ट में वही कवर एंड क्लियर। ओके, एग्जामिनेशन ऑफ अपर 6 cranial nerves, मेरे ख्याल में अगर हम सबसे इजी स्टेशंस की बात करें, अगर आपको जो है शॉर्ट केस में आते हैं तो एक अपर और लोअर 6 cranial nerve बहुत आसान है क्योंकि हम बहुत दफे इसकी प्रैक्टिस भी करते रहते हैं और चलते रहते हैं। तो इसमें भी यही है कि आपको सारी cranial nerves को एक ऑर्गेनाइज वे में करना है, ये नहीं कि आपने फर्स्ट cranial nerve की उसके बाद जंप करके 3 पे आ गए फिर वापस सेकंड पे जा रहे हैं, तो इस तरह से नहीं होना चाहिए। फर्स्ट cranial nerve और फैक्ट्री में आपको, अच्छा एक और बहुत इंपॉर्टेंट चीज ये है कि आप जब चीजें देख रहे हैं खास तौर पे वो चीजें जो एग्जामिनर आपके साथ नहीं देख रहा था, आप उसमें बोले साथ साथ, ताकि एग्जामिनर को पता हो। से फॉर एग्जाम्पल जब जैसे आप डॉट डाल रहे हैं नोज में, अब एग्जामिनर को तो नजर नहीं आ रहा, तो अब आप तब आप थोड़ा सा उसको डिस्क्राइब कर दें कि भाई मुझे कोई भी इसमें जो नेजल सेप्टम की डेविएशन नहीं नजर आ रही, या कोई भी बॉयल अप या कोई इस तरह की स्वेलिंग नहीं है। तो फर्स्ट में हमें स्मेल है, उसके बाद सेकंड क्रेनियल नर्व, अच्छा सेकंड क्रेनियल नर्व के अंदर एक इंपॉर्टेंट चीज ये है, से फॉर एग्जांपल कि कुछ लोग क्या करते हैं कि पहले ही टॉर्च से प्यूपल देखना शुरू कर देते हैं, तो आप इसका भी एक ऐसा तरीका बनाएं, जब आप टॉर्च डालें आंखों में वैसी ब्लरिंग हो जाती है, उसके बाद जब आप इक्विटी चेक करेंगे तो आपको इक्विटी सही तरह से नहीं पता चलेगी इसके। तो इसमें भी यही है, आप पहले इक्विटी चेक करें, फिर कलर विजन है, विजुअल फील्ड आ जाती है, फिर उसके बाद आ जाता है लाइट रिफ्लेक्स है, डायरेक्ट इनडायरेक्ट और फंडोस्कोपी आ जाती है। क्रेनियन अब थर्ड फोर्थ सिक्स एक साथ कर लें क्योंकि सारी इसमें एक्स्ट्रा किलो मूवमेंट्स है, आप एक साथ देख लें। फिर फिफ्थ क्रेनियन नर्व है, उसके ट्राइजेमिनल, उसमें सेंसेशन रहती हैं, कॉर्नियल रिफ्लेक्स, जॉ जैक, पावर। इसी तरह से अगर हम अपर सिक्स क्रेनियन नर्व की बात करते हैं इसके रेलिवेंट एग्जामिनेशन की, तो रेलिवेंट एग्जामिनेशन के अंदर आपको एट्थ क्रेनियन नर्व देखनी है, जिसमें हम मोस्टली जो है पेशेंट का कॉर्नियल रिफ्लेक्स देखते हैं, सेरिबेलर फंक्शन है, प्रोनेटर ड्रिफ्ट है, एक्रोमगैली, प्लांटस, फ्रंटल रिलीज साइंस, और क्वेश्चंस की बात करें तो वो अगेन स्पीच है, सीरियस, मेमोरी, यूरिनरी इनकॉन्टिनेंस, इन चीज़ों के बारे में आप पूछ सकते हैं। लोअर 6 cranial nerves अगेन अब स्टार्ट करते हैं 7 से। उसमें आप फेशियल सिमेट्री, डिफॉर्मिटी देखते हैं, या बाद में हम लोग जो कुछ मैनुअल्स करवाते हैं, मुंह में हवा भरें, आंखें ऊपर करें, इस तरह से जो चीज़ें हैं। 8 cranial nerve में आपको टॉर्च से अगेन देखना है, फिर आपको जो है रेनीज और वेबर टेस्ट करने हैं, विस्पर है। 9, 10 आप एक साथ कर सकते हैं, जिसमें आपको गैग रिफ्लेक्स का वीला देखते हैं। क्रेनियल ऑफ 11 जिसमें आप शोल्डर शेकिंग और हेड टर्निंग देखते हैं। 12 में आपको मोस्टली जो है हम टंग की फेसिकुलेशंस और इंस्पेक्शन में इसकी सिमेट्री, एट्रोफी और मूवमेंट्स वगैरह देखते हैं। अगेन लोअर स्क्रीन पोस्टीरियर फोसा में तो आपको इस एलिमेंट में सेरिबेलम आ जाता है। फंडोस्कोपी देखेंगे वेंट्रिकल जो हाइड्रो को रूल आउट करने के लिए, और इसके बाद प्लांटर्स कॉर्नियल रिफ्लेक्स आ जाता है। क्वेश्चन में अगेन विजन, वॉमिटिंग आ गया, टेंडेंसी टू फॉल। फिर हैंड एग्जामिनेशन यस इम्पॉर्टेंट है, क्योंकि पेरिफेरल मोस्टली रेयरली इस तरह के पेशेंट होते हैं, क्योंकि कभी कभार इस तरह के पेशेंट पड़े होते हैं जिसमें ये होता है कि आपको कोई कार्पल टनल का पेशेंट मिल जाता है, या सेफ कदम कोई अल्नर न्यूरोपैथी का, या इस तरह के पेशेंट आते हैं। तो इसमें भी आपको अगेन पोजीशन देखनी है, कोई डिफॉर्मिटी ऑब्वियस आपको नजर आ रही है, हैंड पे स्वेटिंग, कोई ट्रेमर्स या वेस्टिंग या कोई इस तरह की चीज नहीं है। पल्पेशन में आपको पामर मॉइस्चर, टेम्परेचर, पल्स, कैपिलरी रिफिल। और अच्छा, इसमें हमने तो ये जो जितने भी टेस्ट मेंशन किए हुए हैं, जैसे कैपिलरी रिफिल है, टिनल टेस्ट है, फैलन, वो आपको अपने उस टाइम जब कमांड हो या जो आपको फाइंडिंग है उसके हिसाब से मॉडिफाई करना है, क्योंकि आप एक इतना सारी चीजें नहीं कर सकते वहां पे ना 5 मिनट के अंदर। तो टेस्ट लिखे तो होते काफी सारे, लेकिन आपको जैसे से कार्पल टनल का आ जाता है, कार्पल टनल के अंदर आपका टिनल टेस्ट, फैलन टेस्ट, ये इंपॉर्टेंट होते हैं। तो आपको उसी हिसाब से वहां पे सिनेरियो के हिसाब से कुछ चीजों को मॉडिफाई करना होता है। ओके, रिफ्लेक्सिव है, आपको ऑब्वियसली ब्रेकियोरेडियस है, ग्रैस्पिंग है, हॉफमैन है, सेंसेशंस देखनी होगी साथ में, कोऑर्डिनेशन है, कॉर्टिकल सेंसेशंस हैं। जब रेलिवेंट एग्जामिनेशन की बात करते हैं तो ऑब्वियसली अगर कोई हैंड में आपको चीज, तो हमें नेक की तरफ जाना है ना, कि हो सकता है कि वहां पे हमारे पास सर्वाइकल रेडिकुलोपैथी है, माइलोपैथी है, उसकी वजह से स्पर्लिंग साइन देखना, लर्मिट साइन है, लिम्फ नोड्स हैं। थॉराइड एग्जामिनेशन बहुत इंपॉर्टेंट होता है जब आप हैंड एग्जामिनेशन करते हैं, खासतौर पे क्योंकि हाइपोथाइलेमिया एक पेशेंट। क्वेश्चन में ट्रॉमा, इंजेक्शन या नाइट आपको पेन की पूछना है, ये रेलिवेंट क्वेश्चन है जो इसमें आते हैं। एग्जामिनेशन ऑफ फूड, अच्छा फूड ड्रॉप के पेशेंट में एक्सपोजर बहुत इंपॉर्टेंट है। आपको कम से कम पेशेंट को नी तक लाजमी एक्सपोज करना है, क्योंकि काफी दफा ये होता है कि पेशेंट ऐसे होते हैं जिसको फिब्यूला के नेक का फ्रैक्चर होता है, जिसकी वजह से कॉमन पेरोनियल नर्व की इंजरी होती है, जिसकी वजह से पेशेंट मोस्टली फूड ड्रॉप के साथ आते हैं। या बुलेट का कोई ऐसा से कोई भी ट्रॉमा या पेनिट्रेटिंग ट्रॉमा की हिस्ट्री होती है, तो इसमें भी अगेन आपको सिमेट्री, एट्रोफी, और उसके बाद स्किन के अंदर कोई चेंजिंग है, डिफॉर्मिटी है, प्लांटर फ्लेक्शन, या कुछ मैन्युअर्स हैं कि टांग उठाएं और उसके बाद ऊपर करें, या अपनी उंगलियां पाँव की हिलाएं। पल्पेशन में वही टेम्परेचर, टेंडरनेस, आपको पल्स टोन देखनी है, पावर देखनी है, रिफ्लेक्सेस वगैरह देखने हैं, और सेंसेशंस हैं। अच्छा, रेलिवेंट एग्जामिनेशन बहुत इंपॉर्टेंट है, क्योंकि देखें आपको इसमें रेलिवेंट एग्जामिनेशन में रेलिवेंट एग्जामिनेशन में आपको ऊपर ब्रेन में भी देखना है, पैरासाइटल मैंजियोमा में काफी ज्यादा पेशेंट प्रेजेंट करते हैं फुल ड्रॉप के साथ। तो आपको लोअर लिम्ब को भी एग्जामिनेशन करना है, सेरेनस या स्फिंक्टर्स देखने हैं, स्पाइन को भी, प्रोनेटर ड्रिफ्ट भी देखना है, और साथ में फंडोस्कोपी भी करनी है। तो ये सारे इसके आ जाते हैं। अच्छा, इसमें क्वेश्चंस तो ऑब्वियस ट्रॉमा या इंजेक्शन का, या सेकेंडली सीरियस अगर आप सोचें कि ऊपर पैरासाइटल या कोई इस तरह की चीज है, तो आप ये सारी चीज पूछ सकते हैं। अपर लिम्ब एग्जामिनेशन अगेन मुझे जो लेंथी लगते हैं शॉर्ट केस के हिसाब से, वो अपर और लोअर लिम्ब दोनों बहुत लेंथी हैं, तो आपको इसकी प्रैक्टिस ज्यादा से ज्यादा करनी होगी, क्योंकि मोस्ट ऑफ टाइम हम लोग इसे कंप्लीट नहीं कर पाते, खासतौर पर अपर लिम्ब से ज्यादा लोअर लिम्ब एग्जामिनेशन सबसे ज्यादा टाइम लेता है। तो आपको अभी से इसके शॉर्टकट्स बनाने होंगे, और अपनी चीजों को थोड़ा सा इस तरह से ऑर्गेनाइज करना होगा कि आप 5 मिनट में सारी सारी चीजें कर लें। इसमें इंस्पेक्शन में आपको सिमेट्री, डिफॉर्मिटी, पोजीशन, कार्स या कोई विजिबल पल्सेशंस ये देखनी है। फिर पल्पेशन में आपको वही टेम्परेचर, टेंडरनेस, पल्सेशन, टोन, बल्ब, पावर, रिफ्लेक्सेस देखने हैं। और उसके बाद बाकी ये कुछ अगेन टेस्ट सेंटिनल है, फैलन है, हॉफमैन, अगेन आप ये सारे टेस्ट नहीं कर सकते। जब आपकी जो फाइंडिंग्स हैं आपको उसकी फाइंडिंग के हिसाब से ही वहाँ पे जो टेस्ट जरूरी लगे आप उसको करें, बाकी आप छोड़ सकते हैं, लाजमी नहीं कि आप ये सारे टेस्ट कर सकते। अच्छा, रेलिवेंट एग्जामिनेशन के अंदर अगेन इसमें आपको प्लांटर्स देखने हैं, जाजर के, सर्वाइकल स्पाइन को देखना है, लर्मिड स्पर्लिंग साइन, एक्सिला में को देखना है, लिम्फ नोड या वीसा की डिफॉर्मेशन। क्वेश्चन में अगेन ट्रॉमा, इंजेक्शन, नेक पेन पूछ सकते हैं आप पेशेंट को। तो ये अपर लिम्ब एग्जामिनेशन है। लोअर लिम्ब एग्जामिनेशन सबसे ज्यादा लेंथी होता है, मोस्टली बहुत हर एक एग्जाम में पड़ा होता है, क्योंकि हमारे पास जो भी पेशेंट है इजीली मिल जाते हैं हमें लंबर डिस्क के साथ या इस तरह से। तो लोअर लिम्ब एग्जामिनेशन लाजमी हर एक एग्जामिनेशन मोस्टली स्टूडेंट्स को एनकाउंटर करते हैं जो है ना इसको। तो इसलिए इसकी प्रैक्टिस आप ज्यादा से ज्यादा करें। आपको पता होना चाहिए आप इंस्पेक्शन के अंदर क्या क्या चीजें देखेंगे। और उसके बाद कुछ इसमें मैन्यूज ऐसे होते हैं, जैसे से फॉर एग्जाम्पल आप जब टोन देख रहे हैं, आप टोन के साथ ही इसमें क्या करें, एसएलआर देख लें, एसएलआर के बाद साथ ही फैबर चेक कर लें, फैबर के साथ ही आप उसमें जो है जब नीचे रखने लगे तो आप उसमें जो है प्लांटर्स, तो आप इसका एक पैटर्न इस तरह से बनाएं कि आप लिमिटेड टाइम में सारी की सारी चीजें कंप्लीट कर लें। तो इसके अंदर भी वही है कि इंस्पेक्शन में आपको कोई डिफॉर्मिटी देखनी है, विस्कार या विजिबल पल्सेशन है या नहीं। पल्पेशन में वही सेम चीजें जो हमने देखी थी। हाँ, क्लोनस इसमें इंपॉर्टेंट है, एसएलआर फाइबर है, ये आपको देखना है। रिफ्लेक्सिव में एंकल नियर प्लांटर्स को आपने देखना है। और सेंसेशंस में आपको सेंसरी में वही है कि आप इनमें से कोई एक कर लें, लाइट टच कर लें या फिर जो है आप जो है पिन प्रिक कर लें, बाकी जॉइंट पोजीशन या वाइब्रेशन में भी कोई एक कर लें। इसी तरह से इसके रेलिवेंट एग्जामिनेशन की बात करते हैं तो उसमें स्पाइन का एग्जामिनेशन बहुत इंपॉर्टेंट है। काफी दफा ऐसा होता है कि टाइम बहुत शॉर्ट होता है, लास्ट में क्या करते हैं हम स्पाइन को देख ही नहीं पाते, तो कोई रिकरेंट डिस्क हो या कोई इस तरह की चीज हो तो फिर हमें उसका आइडिया नहीं होता। इसके रेलिवेंट में अपर लिम्ब भी आ जाता है, वॉक, गेट, स्फिंक्टर्स। क्वेश्चन में आप जब काफी दफा पेशेंट की प्राइवेसी आप स्फिंक्टर को चेक नहीं कर सकते तो आप पेशेंट को क्वेश्चन में पूछ सकते हैं कि आपको यूरिन पे कंट्रोल वगैरह है नहीं है, बैक पेन है, सैडनेस है, या क्वेश्चन में पूछ सकते हैं। ओके, सो हाइड्रोसेफलस मोस्टली हम लोग बहुत ज्यादा इनकाउंटर करते हैं अपनी प्रैक्टिस में भी, ओपीडी में भी। बहुत सारे पेशेंट आपके पास हाइड्रोसेफलस के आते हैं। तो इसमें भी यही है कि आपको इंस्पेक्शन में बहुत इंपॉर्टेंट है, आपको फ्रंट से भी देखना है, साइड से भी, बैक से भी, और आपने शेप देखना है, फेस, आईज में प्रोप्टोसिस तो नहीं है, एयर पोजीशन, नोज, जॉ डिटेक्शन, क्लेफ्ट पैलेट। ओके, पल्पेशन में ओएफसी बहुत इंपॉर्टेंट है, बहुत सारे लोगों को पता नहीं चलता ओएफसी का। और आपको एग्जामिनर नोट कर रहा होता है, देख रहा होता है कि आप कहाँ से मेयर कर रहे हैं। तो ओएफसी की प्रैक्टिस अच्छे से कीजिएगा, आपको पता होना चाहिए। फिर इसमें क्वेश्चन में पूछते हैं कि नॉर्मल एट द रेट टाइम ऑफ बर्थ ओएफसी क्या होता है, फिर उसका पैटर्न क्या है इंक्रीज होने का, फर्स्ट 3 मंथ्स में क्या होता है, 6 मंथ्स में क्या होता है, तो आपको इसके बारे में पता होना चाहिए। कॉन्टिनेंस जरूर देखने हैं, सुचर्स को देखना है। उसके बाद जो है इंटरकैंसल डिस्टेंस, काफी दफा खैर हम इसमें नहीं कर पाते, लेकिन ये अगर टाइम हो तो इसको कर लें। ऑस्कल्टेशन है रेलिवेंट एग्जामिनेशन के अंदर। फंडोस्कोपी बहुत इंपॉर्टेंट है। फेस, स्पाइन एग्जामिनेशन, काफी दफा हाइड्रो के बच्चे जो है साथ में स्पाइनल डिफ्रेक्टिज्म के साथ भी आते हैं, एमएमसी वगैरह हो सकते हैं, तो आपको स्पाइन को देखना है। सिंडेक्टिलिटी है या पॉलीडेक्टिलिटी है, लोअर लिम्ब एग्जामिनेशन करना है, साथ में चेस्ट, एब्डोमेन, पेल्विस, सारा आपको एक यू शेप जो हम एग्जामिन करते हैं वो सारी सारी चीजें करनी होगी इसमें। अच्छा, क्वेश्चंस में आपके लिए बहुत इंपॉर्टेंट है इसमें एज का, क्योंकि आपको एज पता होगी तो आपको पता होगा इस एज में ओएफसी नॉर्मल क्या होता है और इस बच्चे का क्या है। साथ में नाजिया वोमिटिंग है दूसरा क्वेश्चन। ओके, तो इंसेफ्लोसील सेम, इसमें भी वही चीजें हैं कि आपको हेड स्वेलिंग की कमांड होगी, आपने इसमें भी वही चीजें देखनी है कि जगह कौन सी है, क्योंकि उसके हिसाब से आपको पता होगा कि कौन सी टाइप की है इंसेफ्लोसील, साइज, शेप, स्किन कलर है, डिस्चार्ज आ रहा है नहीं आ रहा। पल्पेशन के अंदर वही सेम चीजें जो हम पीछे डिस्कस करके आए थे वो सारी की सारी चीजें जाती हैं। ऑस्कल्टेशन बहुत इंपॉर्टेंट है, आपको देखना होगा कि ऑस्कल्टेशन के जो है क्या इसमें कोई विजिबल में भी ओएफसी है, फॉन्टेनर आ गया, सुचर्स, आई बॉल, फेस, आपने सारी चीजें देखनी है। अच्छा, क्वेश्चंस में आप इसमें ट्रॉमा की हिस्ट्री पूछ सकते हैं, स्वेलिंग सिंस बर्थ है या बाद में, ये पूछ सकते हैं।
डॉक्टर तनवीर,
आवाज आ रही है? जी जी।
आप दोबारा से अपनी स्लाइड शेयर कर दो, वो डिस्कनेक्ट हुआ है शायद।
एक सेकेंड।
फिर मैंने कहा नहीं आप लेटो, मैं साफ करती हूँ। फिर मैंने साफ की, फिर कहती है मेरी मम्मा आके साफ करेंगे।
नजर आ रही स्लाइड आपको?
या फुल स्क्रीन कर दो उसको।
एक
यस, ठीक है, सही।
ओके, सो स्पाइना बाइफिडा में आपको अगेन आप इंस्पेक्शन में देखना है साइट कहाँ पर है, लंबर है, डोर्सल स्पाइन में कहाँ पर है, साइज कैसा है, शेप स्किन ऊपर से कैसी है, कोई डिस्चार्ज तो नहीं है, विजिबल पल्सेशंस वगैरह कोई इस तरह की चीज। पल्पेशन में आपको टेम्परेचर देखना है, टेंडरनेस, साइज क्या है उसका, और उसके बाद सरफेस कैसा है, एजेस कैसे हैं, कंसिस्टेंसी कैसी है, फ्लक्चुएशन या ट्रांसलेशन है या नहीं है। कफ इम्पल्स काफी दफा बच्चा छोटा होता है तो हम ये नहीं करवा पाते, लेकिन सारी चीजें आती है। रेलिवेंट एग्जामिनेशन के अंदर अगेन आपको यू शेप पूरा एग्जामिनेशन करना है। इसमें कुछ चीजें बहुत इंपॉर्टेंट होती हैं जिसको आपको मिस नहीं करना, तो उसमें ब्लैडर को देखना होता है, लोअर लिम्ब की मूवमेंट्स को देखना होता है कि मूवमेंट्स हैं या नहीं है, इंग्वाइनल एरिया में साथ में कोई और तो हर्निया या कोई जेनाइटल, ये सारी चीजें इंपॉर्टेंट होती हैं जिसको आपको देखना होता है। क्वेश्चन में अगेन साइज के हेड साइज में चेंजिंग के साथ में इसको हाइड्रो तो नहीं है, स्पिंक्टर्स के बारे में आप पूछ सकते हैं। एक्रोमेगैली अगेन वैसे एक दो दफा हमारे पास जब कराची में एग्जाम हुआ था, हम लोग इस तरह का पेशेंट लेके गए थे तो मुझे याद है एग्जामिनर्स ने मना किया था कि भाई ये एक ऑब्वियस डायग्नोसिस सामने से नजर आ रहा है तो आप इस पेशेंट को मत लेकिन फिर भी एक इम्पॉर्टेंट स्टेशन है, अगर आता है तो आपको पता होना चाहिए। अच्छा, इसके अंदर भी अगेन ये है कि आप, जैसे मैं आपके शेयर करूँ, जब हम लोग तैयारी करते हैं हमने इस तरह एक पिक्चर बनाई। आप अभी अब आपके पास टाइम है, आप कोशिश करें कि अपना कोई इस तरह का पैटर्न बना लें कि जिसमें आपके पास सारी चीजें लिखी हों कि आपने फोरहेड पे ये देखना है, नोज में ये देखना है, आईज में ये देखना है, माउथ है माउथ के अंदर ये देखना है, रेलिवेंट एग्जामिनेशन में ये चीजें। मैं आपसे ये कह रहा हूँ कि हम लोग ये चीजें शेयर कर रहे हैं, ये है तो सही, लेकिन आप अपना अलग से एक फॉर्मेट बनाएं। आप लोगों के पास अभी टाइम है, आप ग्रुप्स बना सकते हैं, और ग्रुप्स में यही है, जैसे 3-4 लोगों का ग्रुप है, आप उसे कहते 3-4 एग्जामिनेशन आप बना के ले आए, 3-4 मैं लिख के ले आता हूँ, फिर आप उसको कंपाइल करें, फिर उसी प्रैक्टिस से उसी तरह से इसको फॉलो करें। जैसे इसमें एक्रोमेगैली में स्पेसिफिक में भी फ्रंटल बॉसिंग है, आपको सुप्राऑर्बिटल रिज देखने हैं, नोज का साइज, लिप्स का साइज, मैक्रोग्लोसिया है नहीं है, स्प्लेइंग ऑफ टीथ है, प्रोग्नेक्सिज्म है, और उसके बाद थिक ईयर लोब्स हैं, क्रेनियल नर्व नर्व 1 में आपको स्मेल देखनी है, बाकी सारी दूसरी क्रेनियल नर्व्स हैं, तो ये सारी चीजें आपको इसमें करनी होंगी। अच्छा, क्वेश्चन के अंदर इसमें इंपॉर्टेंट है, आपको पता होना चाहिए, स्लीप एपनिया के बारे में पूछ सकते हैं, ब्लड प्रेशर का पूछ सकते हैं, जीआई ब्लीडिंग का पूछ सकते हैं, और नाइट रिस्ट पेन जो मोस्टली कार्पेंटर की एसोसिएशन होती है तो इसमें तो आप ये चीजें पूछ सकते हैं।
डॉक्टर तनवीर, वी आर रनिंग शॉर्ट ऑफ टाइम, डॉक्टर असद इज
बस
वेटिंग।
बस बस
प्रेजेंटेशन छोटी सी। ओके।
हाँ, तो आई एग्जामिनेशन प्रोप्टोसिस बहुत इंपॉर्टेंट है, इसकी प्रैक्टिस आप ज़्यादा से ज़्यादा करें क्योंकि हमें मेजरमेंट्स का थोड़ा सा आइडिया नहीं होता है। इसमें भी आपको जो है इंस्पेक्शन में जो चीज़ें हैं वो देखनी है, तो वही ये टॉसिस क्या है, डिटेक्शन, विजिबल पल्सेशन है या नहीं है, पल्पेशन में टेम्परेचर, टेंडरनेस वगैरह आ जाती है, रेलिवेंट एग्जामिनेशन में पल्स, टेम्परेचर, थायराइड, हैंड ट्रेमर्स वगैरह आ जाते हैं। सेंसरी सिस्टम, मोटर सिस्टम बहुत रेयरली, मैंने तो खैर नहीं देखा कोई इस तरह के स्टेशन, लेकिन कभी भी आ सकते हैं आपके पास। अच्छा, लास्ट में यही है कि आपके पास 5 मिनट होते हैं जिसमें आपने एग्जामिनर को कंप्रेस करना है, तो आपका जो एग्जामिनेशन का पैटर्न है वो बहुत कंपाइल होना चाहिए। अगर आप हिप हैजर्डली जाते हैं, ऊपर नीचे से चीजें कर रहे हैं, तो एग्जामिनर के ऊपर इसका अच्छा इंप्रेशन नहीं जाता। तो आपका फेलियर रीजंस भी यही होते हैं कि अगर आपने एग्जामिनेशन टाइम पे कंप्लीट नहीं किया, या आपने कोई फाइंडिंग पिक नहीं की, कोई भी आपने जो है जो इसमें इम्पोर्टेंट फाइंडिंग है आपने उसको मिस कर दिया, तो ये भी एक साइन है फेलियर का। आपने रेलिवेंट के लिए परमिशन नहीं ली, पेशेंट को कवर नहीं किया प्रॉपरली, और इसके बाद जब टाइम इरेलीवेंट डिस्क्रिप्शन में आपने अपना टाइम वेस्ट किया, डायरेक्टली डायग्नोसिस पे जंप कर दिया, तो ये सारे वो मतलब चीजें हैं जिसमें आपके फेलियर के चांसेस बढ़ जाते हैं। थैंक यू।
Okay. Thank you so much, Dr. Tanveer. And I guess everyone has a good idea about the short cases now. We almost covered all the cases. समटाइम्स ये होता है कि वो एक ही जो है वो केस को दो अलग अलग नामों से वो दे देते हैं, ठीक है, बट सेम मोर और लेस वही कहानी होती है जो कि आपको बताई जाती है कि आप ये करें। लाइक हायर मेंटल फंक्शन है, ठीक है, आप उसको मिनी मेंटल भी कह सकते हैं, ठीक है, उसको लो साइंस भी कह सकते हैं, तो वो डिफरेंट चीजें हो जाती है समटाइम्स, बट ग्लॉसली जो है वो उसका मकसद वही होता है, ठीक है। तो थोड़ी बहुत चेंजेस के साथ में यू कैन मैनेज योर शॉर्ट केस। सो अगेन डॉक्टर तनवीर, thank you so much. I would like to just give a very short review talk about the long cases now. Then we can move to the main presentation of Dr. Asad Abbas, and then we will discuss the cases. ज़्यादा मैं टाइम नहीं दूंगा. I will just take 5-7 minutes, and so this is what has happened. कि जो हमारे पास कैंडिडेट्स हैं उसमें as you can see we have equal number of people who are fresh and repeaters, ठीक है. सो किसी इसका हल्के से मतलब नहीं ये दिखाना कि आप कोई फेल हो चुके हैं, इसका कोई बड़ा प्रॉब्लम है. इट्स नॉट दैट प्रॉब्लम. द थिंग इज कि आपको आइडिया होना चाहिए कि बहुत सारे लोग हमारे पास जो रिपीट कर रहे होते हैं एग्जाम, तो वो कुछ ऐसी मिस्टेक्स कर रहे होते हैं बिकॉज वो उनको अंदाजा भी नहीं हो रहा होता, ठीक है. उसी के लिए थोड़ा सा कंसेप्ट क्लियर करने के लिए आई वुड लाइक टू टॉक अ बिट अबाउट द लॉन्ग केसेस, स्पेशली बिफोर गोइंग टू लॉन्ग केसेस. आप ये भी देख लें कि मोस्ट ऑफ पीपल आर हियर हु हैवंट पास्ड देयर टोट्स येट ना. तो कल वाला सेशन उनके लिए इंपॉर्टेंट होने जा रहा है कि ताकि जो है वो टोट्स की प्रैक्टिस कर सकेंगे. So talking about the long cases, so these are the general categories as you can see. So जो कि हमारे पास कॉमनली होती है लॉन्ग केसेस के अंदर, ठीक है. सो मैं हमेशा से कहता हूँ कि बहुत गिने चुने से लॉन्ग केसेस हैं, ठीक है, एंड यू हैव टू प्रिपेयर ओनली दोज केसेस. अब आप बोले कोई ऐसा केस जो कि बिल्कुल रेयर है एंड यू आर फुल ऑन प्रैक्टिसिंग दैट केस, ठीक है, तो वो आपको प्रॉब्लम करता है, ठीक है. इसमें बहुत सारी चीजें हैं इसके अंदर जो आपको कॉमन केसेस हैं, यू हैव टू स्टिक टू दैट. उनकी बहुत अच्छी से प्रैक्टिस होनी चाहिए. यू कैन नॉट मिस एनीथिंग ऑन दोज केसेस. कुछ रेयर केसेस होते हैं, यू कैन मिस अ लॉट ऑफ थिंग एंड स्टिल पास द एग्जाम बिकॉज वो रेयर केसेस हैं. दोज रेयर differentials or diagnosis shouldn't be the first differential of your case. ये बहुत बड़ी मिस्टेक्स करते हैं हमारे लोग. अक्सर क्या होता है कि उन्होंने पेशेंट देखे भी होते हैं, ठीक है, और जनरली है. मैं उसमें कभी किसी को ये नहीं कहता कि कोई बुरी बात है पेशेंट देखना, बट पेशेंट देखना एक हद तक होना चाहिए. पेशेंट याद करना, पेशेंट को रट्टे लगाना, पेशेंट की एक एक फाइंडिंग को पता होना, ये सब बिल्कुल गलत है. आपका पूरा जो है एग्जाम में वो बर्बाद हो जाता है इससे. बिकॉज होता क्या है कि आपके माइंड में है, फॉर एग्जांपल एक पेशेंट है, उसको ब्रेन लीजन है, ठीक है, और वो फ्रंटल लोब लीजन है, सारे उसके फीचर्स जो हैं वो मोर और लेस न्यूप्लास्टिक भी हैं बिकॉज उसकी लॉन्ग हिस्ट्री है, 5-6 महीने की हिस्ट्री है, बट उसका जो डायग्नोसिस है वो उसका फंगस लीजन है, फंगल लीजन है. कोई खास यंग पेशेंट है, कोई खास उसको इम्यूनो कॉम्प्रोमाइज भी नहीं है, ठीक है, और आपने देख लिया वो पेशेंट पहले से एंड यू आर टॉकिंग अबाउट द फंगल लीजन ऑल द टाइम. आई मीन स्टार्ट से ही आपका पहला डिफरेंशियल जो है ना फंगस की तरफ जा रहा है. तो हाउ कैन someone pass you on this case because he knows कि जो सारे फीचर है मोर और लेस वो सिमिलर हैं, वही के जो मेनिंजियोमा में भी हो सकते हैं, ग्लैमो में भी हो सकते हैं, एंड यू आर नॉट टॉकिंग अबाउट द कॉमन थिंग्स फर्स्ट एंड रादर गोइंग टू अ रेयर डायग्नोसिस. सो ऐसे नहीं करना आपने, ठीक है. तो ये सबसे बड़ी मिस्टेक है जो पेशेंट देखने के बाद होती है. इसलिए मैं हमेशा सबको सजेस्ट करता हूँ, डू नॉट सी ऑल द पेशेंट, या देखने भी हैं तो जस्ट स्पेंड 3 to 5 minutes with the patient. उसमें भी सारा कुछ, like for example if you are going to some ward and there are 10-15 patients who can be the long cases, just go and ask 2-3 relevant question to the patient. For example, what are his major complaints, ठीक है, वो कहता है कि मुझे हेडेक और सीजर्स हो रहे हैं, ठीक है. आप उससे रिलेटेड आपको 1 या 2 सवाल और करने हैं, आप उसकी ड्यूरेशन पूछ सकते हैं, ठीक है. आप इसी तरीके से और उसकी कोई भी चीज आप पूछना चाहते हैं तो वो आप पूछ लें. कोई भी आपको लगता है कि इसके अंदर हेयरिंग हो सकती है प्रॉब्लम, इसके अंदर विजन प्रॉब्लम हो सकती है, ठीक है, या फिर वीकनेस हो सकती है किसी साइड के ऊपर जो पेशेंट नहीं बता रहा, तो जस्ट आस्क द रेलेवेंट क्वेश्चन और इसी के ऊपर मेक योर डिफरेंशियल, मेक योर डायग्नोसिस, एंड उसी से रेलेवेंट 2 या 3 जो है वो क्लिनिकल साइंस आप कर लें, ठीक है. इफ यू हैव द फंडोस्कोप विद यू, गो एंड चेक द फंडोस्कोप. कोई वीकनेस का कंप्लेन कर रहा है पेशेंट तो जस्ट see the power of limbs. और इसके अलावा आप रोटेटिव कर सकते हैं, प्लांटर्स कर सकते हैं, and that should be enough to have an आइडिया कि ये पेशेंट का डिफरेंशियल आफ्टर योर हिस्ट्री जो आपने शॉर्ट से लिए वो कितना नैरो डाउन आप कर सकते हैं ऑन द बेसिस ऑफ योर एग्जामिनेशन। एंड उसके बाद जस्ट सी द स्कैन, और वही अगर आपका डायग्नोसिस जो आप बना रहे हो जो आपके डिफरेंशियल है वो अपने माइंड में रखते हुए जस्ट सी द स्कैन्स, और स्कैन देखने के बाद जस्ट लीव दैट पेशेंट नाउ। ठीक है, तो ये 3 से 5 मिनट में बहुत इजीली आप कर सकते हैं। इससे ज्यादा इफ यू गो डीप इनटू द पेशेंट और आपको एक एक फाइंडिंग आप याद करने लग जाएंगे, एक एक चीजें आप देखने लग जाएंगे, तो दैट विल बी अ बिग ट्रबल फॉर यू इन द एग्जाम। ये होता है, बहुत कॉमनली होता है। आई हैव बीन द ऑब्जर्वर इन द एग्जाम। इसके अलावा ये सारे सेशंस जो हैं इन सब के अंदर हम यही देखते आ रहे हैं कि सबके साथ ये प्रॉब्लम होता है कि थोड़ा सा भी पेशेंट का आइडिया होता है तो वो समहाउ उनकी पूरी डिस्कशन, उनका पूरा माइंडसेट उसी डायग्नोसिस की तरफ जा रहा होता है और वो फिर जो है ब्लंडर्स कर रहे होते हैं। ठीक है, तो इम्पोर्टेंट ये है। तो ये कैटेगरीज हैं सिंपल सिंपल, इसके अलावा बहुत सी और कैटेगरीज हो सकती हैं, बट जनरली यही होती हैं जो कि आती हैं इसके अंदर। ठीक है, आजकल देर आर इक्वल नंबर ऑफ क्रेनियल एंड स्पाइनल केसेस, सो यू कैन हैव एनी ऑफ द वन। ठीक है, तो 50-50% चांस है आपके पास क्रेनियल भी आ सकता है, स्पाइनल भी आ सकता है। सो यू हैव टू प्रैक्टिस बोथ द थिंग्स इक्वली। पहले होता था क्रेनियल केसेस ज्यादा होते थे, ओनली 30%, 25% केसेस स्पाइनल के वो लॉन्ग केसेस में रखते थे, बट नाउ दे हैव चेंज इट, सो इक्वल नंबर ऑफ केसेस आर देयर, सो कुछ भी आ सकता है आपके पास। मार्किंग्स, ये स्कीम होती है जनरली मार्किंग की। ठीक है, हिस्ट्री एग्जामिनेशन हैव 20 मार्क्स। ठीक है, उसके अंदर टोटल हिस्ट्री एग्जामिनेशन। ठीक है, बट ये जो हिस्ट्री एग्जामिनेशन है ये आपका सेटअप करता है द होल केस। तो हिस्ट्री एग्जामिनेशन जो आपको 20 मार्क्स लग रहे हैं, यू कैन थिंक यार ये तो बस 20 मार्क्स हैं, बाकी मार्क्स तो नहीं है इतने ज़्यादा, 80 मार्क्स तो बाद में होने। बट ये 20 मार्क्स सबसे ज़्यादा इंपॉर्टेंट है, बिकॉज इफ यू हैव अ गुड हिस्ट्री, इफ यू डू द गुड एग्जामिनेशन, ओनली देन यू कैन जस्टिफाई योर फाइंडिंग्स एंड योर केस एंड योर डिफरेंशियल्स ओनली, एंड तभी मैनेजमेंट की बात की जा सकती है। सो फोकस ऑन दोज 20 मार्क्स, सबसे इंपॉर्टेंट है, जिसे बता रहा हूँ बार बार। अगर आपकी हिस्ट्री एग्जामिनेशन अच्छी है, योर इम्प्रेशन विल बी गुड ऑन द एग्जामिनर। ठीक है, तो ओनली देन यू कैन हैव कुछ आप फेवर ले सकते हैं उनसे। ठीक है, फेवर क्या होती है? फेवर में यही होता है कि वो आपको कुछ ब्लंट क्वेश्चन ना करेगी, ठीक है, कुछ ट्रिकी क्वेश्चन ना करेगी। अगर आपने बहुत स्मूथली अपना हिस्ट्री एग्जामिनेशन किया है एंड देन यू कैन प्रेजेंट इट वेरी वेल। प्रेजेंटेशन से प्रेजेंटेशन नहीं होती, इट्स द जस्टिफिकेशन एज वेल, बिकॉज आप कोई भी जो है वो क्लिनिकल हिस्ट्री दे रहे हैं तो आपको उसमें कोई डिफरेंशियल्स आपको जस्टिफाई भी तो करना है ना वहाँ पर। तो वो अगेन इंपॉर्टेंट है, उसके लिए हिस्ट्री एग्जामिनेशन इज द मोस्ट इंपॉर्टेंट थिंग। देन यू हैव द केस प्रेजेंटेशन जब आप कर रहे होते हैं उसके अंदर, तो ओनली 5 मार्क्स फॉर द प्रेजेंटेशन। बाकी जो पॉजिटिव फाइंडिंग्स, एग्जामिनर्स हैव ऑलरेडी सीन दोज केसेस एंड दे हैव नोटेड डाउन द पॉजिटिव फाइंडिंग। जनरली किसी वार्ड से अगर जा रहा होता है तो वो वार्ड भी फाइल के ऊपर मेंशन करके भेजता है कि आप दीज आर द फाइंडिंग्स। ठीक है, और वो जो रेलिवेंट उनका पर्सन होता है रिप्रेजेंटेटिव, वो हैंड ओवर करता है एग्जामिनर के। सो दे हैव द फाइंडिंग्स एज वेल, तो फिर आपको वो फाइंडिंग्स पिक करना भी इंपॉर्टेंट है। समटाइम्स नेगेटिव फाइंडिंग्स आर इक्वली इंपॉर्टेंट। ठीक है, जब आपके पास पॉजिटिव कम आ रही होती है तो यू हैव टू नैरो डाउन योर डिफरेंशियल ऑन द बेसिस ऑफ नेगेटिव फाइंडिंग्स जो कि इंपॉर्टेंट हो सकती हैं, लाइक प्लांटर्स, लाइक प्रोनेटर ड्रिफ्ट। ठीक है, लाइक फंडोस्कोपी। सो इस तरह की चीजें हैं वो इंपॉर्टेंट होती हैं इसके अंदर, एंड उसी के बेसिस के ऊपर यू विल जस्टिफाई योर डायग्नोसिस। डायग्नोसिस के ऊपर मोस्ट ऑफ द पीपल कंफ्यूज कि यार अगर हमारा डायग्नोसिस जो फर्स्ट इंप्रेशन है या फर्स्ट डायग्नोसिस अगर वो सही नहीं हुआ तो फिर क्या होगा। ठीक है, जो अगर वो सही नहीं हुआ तो बहुत बड़ा प्रॉब्लम हो भी सकता है और नहीं भी हो सकता है, इक्वल है, कोई ऐसा लेना देना उसके साथ में नहीं है। अगर बहुत कॉमन एक डायग्नोसिस है एंड यू आर मिसिंग इट, ठीक है, डिस्पाइट द फैक्ट एग्जामिनर इज ट्राइंग टू जो है वो आपको हेल्प करने की कोशिश कर रहा है, बट यू आर अनेबल टू पिक दोज, आई मीन जो भी उन्होंने हेल्प आपको कर रहे हैं। ठीक है, तो फिर प्रॉब्लम हो सकता है। बट अगर कोई रेयर केसेस है या अनलाइकली केसेस है या लेस कॉमन केस है और उसका आपका वो डिफरेंशियल में नहीं भी है, इवन देन यू कैन पास योर एग्जाम। ठीक है, सो दिस इज वेरी इंपॉर्टेंट कि आपका डिफरेंशियल आइडियली होना चाहिए, बट नहीं भी है तो कोई मसला नहीं है उसके अंदर। इसी वजह से कहते हैं कि आपने डिफरेंशियल जो है वो आपने लॉन्ग बनाना है और अकॉर्डिंग टू दिस लिस्ट बनाना। आप बोले यार कि मेरा फर्स्ट डायग्नोसिस लाइकली न्यूप्लास्टिक है, कैन बी इन्फेक्टिव, कैन बी वेस्कुलर, और उनमें से एक एक दो जो कि आपको लोकेशन के हिसाब से, हिस्ट्री के हिसाब से समझ में आ रहे हैं, यू जस्ट पुट देम ओवर देयर। ठीक है, और बाकी पे डिस्कशन होती है, यू नो वेरी वेल के 2 एग्जामिनर्स होते हैं, एक जो है वो थोड़ा इन्वेस्टिगेशन और इनिशियल चीज़ों के ऊपर, बल्कि एक जो है वो केस आपसे पूछ रहा होता है और दूसरा फिर आपसे मैनेजमेंट के ऊपर बात कर रहा होता है। ठीक है, सो ये चीजें हैं जो कि इम्पोर्टेंट है लॉन्ग केस के हिसाब से. कुछ और चीजें आई विल शेयर इट लेटर. आई गेस वी कैन टेक डॉक्टर असद अब्बास right now because he is busy. He has to leave. So, uh, Dr. Asad, I'm unmuting you and you can share your screen as well. Dr. Asad Abbas, again, he's from JPMC and he has been in Nottingham for quite good time. He has done his FCPS from JPMC in his first attempt, and then he has also done the FRCS as well, right? And he is going to Leeds for a vascular fellowship in a short period of time. So, I mean, I'm very glad to have him on this course. And he has very much experience of giving the local and the international exams, and he has been coordinating with us in such courses. So he has been senior to me along with Dr. Ali Afzal. So they both helped us a lot, especially the JPMC candidates for the FCPS exam. So over to you, Dr. Asad. And if you have a presentation, you can share it or you can just talk.
Thank you very much for the overwhelming introduction. Now I'm struggling to get the presentation up. How do I share it?
Dr. Asad, आपकी आवाज बहुत ज़्यादा क्लियर नहीं है. I guess you are using some hands free, I guess. So I'm not sure if that's a good idea.
Yeah. Can you hear me now? You can't.
I mean, clear. We can hear you, but it's not that much clear. So if you can use the direct speaker or the mic, that will be, I mean, better, I guess, rather than using the hands free.
Okay. I'll figure out. Is it better now?
A little better, yeah. I mean, it's better.
Better now.
But you will have to speak loud, I guess. थोड़ा कम आ रही हो.
Speak loud, I guess. थोड़ा कम आ रही हो. Is it better now?
No, it's not. I mean, you can then have the hands-free one.
I mean, you can then have the one. No, really. Try to be louder then, and then see if it works.
Yeah, it's better now.
No, it's true. Way better. Okay, so can you see my screen?
Yeah.
Yeah. So thank you for the overwhelming introduction. Just in the next few minutes, I will try and focus on the Viva preparation in neurosurgery. I'm more focused on what we say the FCPS Viva. I understand that there's no formal Viva FCPS now, but all the exams, when you're actually, by Viva means actually having a conversation with the examiner. So it is been distributed in a lot of situations where you have to speak to the examiner about in talks and so in long cases and everywhere. And that's what I'm trying to focus is about more discussing with the examiner when he's asking you questions or other questions. And this Viva, the examiner is trying to establish the depth of your understanding, how you make decision, and how clear are you about your concepts. And this is not just about knowledge and practice, it's more about your attitude as well, how you communicate with the patient, and how confident you look on the day of the exam. And that counts as well with a major extent. So as I was mentioning that Viva is, there's no formal Viva anymore in FCPS, but you do get asked questions in different situations like short cases, long cases, and OSCEs. And that's what formats your Viva these days. And they can be really based on your day-to-day practice, such as your emergency work, your elective work, and specifically sometimes want you to know about the management. patients. Not important, that's fine. They're just expecting you to get day one consultant. And important thing is to be safe on day one rather than just trying to do something extraordinary in the patients. For example, just a very crucial example is when people are talking about third ventricular lesions and all. So the exam Viva questions, you answer should not be trying to go for endoscopic removal of the hollow cyst in the middle of the night. It should rather be bilateral EVDs. So that's what the effective of the day one consultant.
We can only see your first slide. I'm not
Decades
sure if you are scrolling through the slides. So we are only seeing the first slide. And
Is it moving? Oh, sorry. So, okay, just let me just try and share it again. Let me say,
and again, I'm थोड़ा सा
Uh,
request है कि अगर थोड़ा सा और loud if you can speak.
okay, I'll try and shout now. See if it's. We got the newer
Yeah.
slides now. Is it moving now?
We have the 4 domains in Viva and Viva format.
Is the new slide on? Oh, okay, that's great then. Yeah. So this is what we're talking about the Viva format. It can go into different situations, and then obviously there's no more imaging in the because there's no more Viva, but you can be Viva on the images.
आपकी आवाज नहीं आ रही है guess. Dr. Asad.
Is it better now?
हाँ आप सही आ रही है.
Sorry. Okay. Sorry, there's been some problem with my internet, I think. I'm sorry about that. So the core domains they will assess you mainly on is it's basically covering everything about neurosurgery, but you need to maybe just focus and structure your preparation in terms of having knowledge about the basic sciences and neuroanatomy, common surgical pathologies, as Farrukh and Tanweer have mentioned about, and then you have to know the operative approaches that you will be talking and discussing about, and obviously relevant surgical anatomy, and then pre and post operative management, complications, and sometimes ITU management. Professionalism and ethics, it's a smaller part of the FCPS exam, but it still counts. Sometimes 1 or 2 marks can make a lot of difference. Your professionalism and your ethics can really between you. From now onwards, if you're trying to prepare for the Vivas, it's best to just practice. Unless you speak up, you won't be able to speak in front of examiners. So you need to practice in front of your seniors, your peers, your colleagues, even juniors. Sometimes you can just take your on-call trainee around and then just ask him to show you a scan and then explain it to them. And then I still believe that the exam is conducted in English, so try and speak in English when you're explaining the scans and everything, rather than just talking in your mother tongue or Urdu, because that's not the format of the exam, and then you might be caught out in trying to translate what to say in English, which is supposed to be, which you are generally explaining to patients in Urdu or other languages. You need to think about very precise and comprehensive answers. Don't try and just beat about the bush and then keep talking around and around, and don't not mention the actual point which the examiner is trying to find out. And you have to have the reason behind what you're saying. Don't try and just memorize and then say. I know there's a lot of classification systems that you have to memorize, but at the same time, don't just remain on the classification. You need to know if certain classification is made, what's the importance of that grade. For example, if there's ICH score, then you should know that why is the posterior fossa bleed is given 1 extra mark, why is the intraventricular extension given 1 extra mark, and so on and so forth. When you're answering these questions, you need to be very clear in your answers, and if you don't know or if you don't understand the question, just ask what they're trying to identify. Because if you don't understand the question fully, you would probably just give a vague answer and you won't be able to satisfy the examiner. And sometimes they have key points written down in front of them and you have to say those key words. Otherwise, you will be in trouble by not mentioning the key terms. And when you're answering your questions, just organize it in a better way. Just start with maybe definition and then key points, and then go to further elaborative management. And there would be situations where you wouldn't know the answer, because sometimes the examiner asking you honor level question or distinction level question. You can just say that I don't, or you can say, can I come back to this? So in a way, you're just deflecting the question for then, and then focus on the next one. Because if you just keep focusing and trying questions after that, and sometimes you get an idea from the next question or what the examiner wanted to ask in the previous question, just because there's a hint. This is a hunt, duck hunting game. I'm sure a lot of you would have played this on the old systems like Atari and Sega. Oh, this is what I tend to tell my juniors about the exam. So there are two people who are more likely to get away from the examiner, because the examiner, imagine, is trying to shoot you down. So if you try and stick to the basics, you will stay at the bottom of the tier, but you will still go through and pass the exam. Or you need to be extraordinary to be able to miss the examiner shot and then just sail your examination. But if you're right in the middle, if you're trying to just show off, or if you're trying to just impress the examiner with something that you actually don't know, or you try and just for example, I remember somewhere in the examination, he had a meningioma, and he was trying to just give the grading on the basis of the MRI, that this is going to be a hemangioperocytoma or something like that, which is not, as I said, it's not the basic answer they're asking for. They're just looking for the straightforward answers, and then you can go into the details, and then you will get hit there. Be careful about how you structure your answers during the Viva, so the questions. I think Farrukh and Tanweer have touched upon on the commonly asked themes, but this is what they're trying to focus on. The one thing that I wanted to specifically mention is that CPSP really loves ATLS. So if there's a trauma patient of whatever sort, head injury, spinal injury, whatever, if you don't say ATLS protocol, then you're in deep trouble, because they love this term in your showcases, in your talks, or whatever that is. ATLS is a key term to mention in trauma patients, and then you can build up on it. It doesn't take too long. You can say based on the ATL protocol after maintaining ABC or airway breathing and circulation, and then I will go on to the assessment of the, for example, head injury and spinal injuries and all that. These are the common mistakes that I'd like to point out. Is sometimes you just know the answer. You have probably seen the patient and you're just guessing without logic, and a lot of times you just mix the patients, and the patients are sometimes similarly presenting in their actual presentation during the exam, and you would think, oh, this might be the other patient, and you might just mix your findings or your rote learning. So you need to be very careful. You shouldn't be guessing just without having a logic behind it. Whatever you say, you should know the reason what you are trying to say. Otherwise, you can get caught very easily. The examiner would find out. Don't worry. They've seen lots of more candidates before you, and they can pick up easily who is just trying to just bluff and who actually knows what he's talking about. And if there's a simple question, then give a simple answer. Don't try and overcomplicate
questions. If they say, oh, if this is a D10 lesion, you're doing a thoracotomy, what level will you give an incision? Don't say that in the cervical spine there's +1, in thoracic spine there is +2, there's lumbar spine +3. Just say this is T8, I'm just going to give an incision at the 6th rib, that's it. If he's asking a simple question, give a simple answer. Because sometimes you just will go into a more complicated answer, and as in other words they say, you'll dig your own grave. So do not try and do that. Just stick to the a simple answer. To elaborate, unless they ask you to elaborate on your questions, try and just give a straightforward one sentence answer to the questions, and then if they want you to elaborate, then you can elaborate so far on that. And sometimes the examiners will challenge you to find out what you are trying to say. That then you're wrong. So if you have said something which you believe is correct, just explain that. Don't just try and change. Oh, no, this can't be this aneurysm, for example. Is more likely to be this one because they've just asked you, why do you think this is this aneurysm? So just think about it when you first answer, and when the examiner is asking for explanation, don't just go on a back foot and start changing your answers or just turning around from what you have said. And whenever you are talking, just be clear and very precise in your answers. Do not just say mumble around, and then don't just use non-professional terms or with the examiners, because that would just really maybe they just should piss them off, and then you'll probably end up in trouble. And a lot of the examiners, I know some of the examiners are really strict, but a lot of these examiners are there to help pass your exams because they've been into that situation and they have their candidates going to similar situations. So they're trying to help you as well. So do not ignore their hints. If they are trying to tell you something, pick up that hint, think about it, and then focus on the soft skills. And when you're answering the questions, just you can actually think aloud that this is, or if you're reasoning it, or why would certain thing happen, just you can mention that. You can think aloud that this is why this would be a problem, rather than just thinking and then be quiet in your mind for 5 minutes and then trying to come up with an answer. So you can think aloud in front of the examiner as well. And as I said, try to be structured and systematic, and then be confident. Sometimes you can use diagrams. I'm not sure if in FCPS they allow you pen and paper, but this trick has really helped me in a lot of exams. Because a lot of times you're struggling to find the words. You can just draw a diagram, and then that really helps, and that also shows to the examiner that you really know the topic or that particular point. So, for example, drawing a graph which is related to that finding, or a table which is related, to really make the examiner understand. And practice is the key, and you need to practice in the time condition. You need to know how long I think it's still half an hour long case. So you need to know that how many minutes you need to get to history and examination, and in how many minutes you'll have to be with the examiner for the examination and all that setting. And obviously this course is to simulate the exam pressure. So tomorrow when you have this practice sessions, just come up with the ideas and then try and answer questions as you go across. It's important that you balance your knowledge and your technique, because if you're just knowledgeable, if you don't have the technique, you will fail. And if it's all technique, and if you don't have the knowledge, you'll fail as well. You can learn from your mentors and your senior candidates who have passed the exam recently, because they are the ones who would know the exam very well, and they would have all these skills that's required for the examination, the exit exam, very fresh in their minds. And at the same time, when you're in the exam, stay calm and be respectful to obviously the patient, and do not lose a professional attire. Just stay professional, keep your language professional, and then keep yourself calm. Thank you very much, and wish you best of luck for your exams. Yeah, if you guys have any questions later on, or more practice, we can. I'm sure Farrukh has my number. He can forward me your queries or questions, and I'll be happy to help.
Farrukh, you are muted, I think.
हाँ sorry मैं बोल रहा था so thank you Dr. Ali. So I was saying that you guys very well know about these long case distributions. ठीक है, 30 minutes are for the student examination, but major part is for the examination. So kindly make sure that your history is completed within the 10 minutes time. Ideal is 8 or 7 minutes even. Sometimes simple cases are there and you do not have longer histories. But I was just saying that you do not need to dig into the personal histories and the family histories or the living circumstances of the patient. So that is not going to help diagnose something or differentiate or exclude anything. ठीक है, sometimes there are cases आप already history ले चुके हैं, the presenting complaints and HOPCs you have already taken. So you know very well कि यहाँ पर कोई hereditary problem या कोई ऐसी familial history हो सकती है या नहीं हो सकती. If not, you do not go deep into it. ठीक है. So history सबसे बड़ा problem होता है. Sometimes the candidate is very slow to ask different questions. ठीक है, या वो बहुत ज़्यादा सवाल कर रहा होता है and they are repeating the questions. So that is where they destroy their time. So वो आपने नहीं करना. So बेहतर ये है कि आप उसको within 10 minutes आप complete कर लें and then just go to the examination. ये सब आप लोगों को already provided भी है on the YouTube channel as well. You have, so distribution should be there. Clear होनी चाहिए, आपको आइडिया होना चाहिए कि ये आपने करना है. Make sure that you try to complete your history and examination within 25 to 28 minutes. At least you can have, I mean, you should have 2 minutes time. That's the must. ठीक है. Ideally, if you get the 5 minutes time, that is much better so that you can prepare your, I mean, the whole history and examination to present. ठीक है. Sometimes आप पहले भी स्टार्ट कर सकते हैं your viva thing. आप कह सकते हैं कि I'm ready to present. ठीक है, but not necessarily कि आप जो है वो, मतलब अगर आप कर चुके हैं तो wasting your time and sitting there कि मैं अपना पूरा 30 minutes लेना है is not a good idea. ठीक है. ऑलरेडी डॉक्टर असद ने बात की है, डू नॉट थ्रो टू मच. जितना बताने की जरूरत है जस्ट स्टिक टू दैट. सिंपल इज दैट कि हम कहते हैं कि यार फॉर एग्जांपल आफ्टर हिस्ट्री एग्जामिनेशन और जस्ट द हिस्ट्री समवन द एग्जामिनर आस्क यू कि आपको क्या लग रहा है, व्हाट काइंड ऑफ पैथोलॉजी इज देयर और व्हाट आर यू लुकिंग, आई मीन व्हाट आर यू डीलिंग विद. ठीक है, तो यू कैन सिंपली से कि दिस लुक्स टू बी अ cranial केस एंड मोस्ट लाइकली सुpratentorial. डू नॉट जंप टू द कि meningioma है यहाँ का या वहाँ का है. सो यू, दिस इज द वे टू present your case. just take a simple answer दें कि this can be the supratentorial region. Only when he asks यार कहाँ पर हो सकता है supratentorial, you can go that it can be the right frontal or the left frontal or the midline or the posterior fossa. So अपने क्वेश्चंस को सेव करें एंड थोड़ा स्लो अपने आप को स्लो डाउन करें. सब कुछ बताने की जरूरत नहीं है एक ही गो के अंदर. फॉर एग्जांपल आपने हिस्ट्री के बाद डायरेक्टली कह दिया कि दिस लुक्स टू बी मेडुलोब्लास्टोमा. सो अब बहुत ज्यादा हो जाएगा ये, ठीक है, कि आपके लिए मुश्किल हो जाएगा कि फिर वहां से आगे बढ़ना, बिकॉज एग्जामिनर्स के पास बहुत टाइम होगा बाद में आपको रीड करने का. सो थोड़ा सा आप उसको स्लो डाउन करना. कुछ चीजें होती हैं जो कि इंपॉर्टेंट होती हैं, जो कि एग्जामिनर्स वांट्स टू हेयर फ्रॉम यू व्हेन यू आर टेकिंग द हिस्ट्री. तो वो आपने पर्टिकुलरली बात करनी है कि बहुत लाउडली क्लियरली, और बाकी क्वेश्चन से हट के आपने अलग से पूछना है. ठीक है, आपने हेडेक हिस्ट्री ले रहे हैं तो उसी के अंदर मर्ज नहीं करना. आपने बहुत क्लियरली पूछना है कि यार इज देयर अ मॉर्निंग हेडेक और नॉट. ठीक है, इसी तरीके से इज देयर एनी रिलीफ ऑफ हेडेक आफ्टर द वॉमिटिंग. ठीक है, तो वो आपने बहुत क्लियरली पूछना. एग्जामिनर वांट्स टू नोटिस दिस थिंग्स. ठीक है, सिमिलरली किसी को टीबी का हिस्ट्री का आपने पूछना है और आपको डिफरेंशियल में लग रहा है तो जस्ट क्लियरली आप लाउडली पूछें कि आपको कोई आपके या फैमिली हिस्ट्री या जो भी आप पूछना चाह रहे हैं कि टीबी तो नहीं है. सिमिलरली ट्रॉमा के बारे में भी यही सवाल है. ठीक है, ये चीजें होती हैं. एग्जामिनेशन में भी इसी तरीके से, बिकॉज इफ यू आर लुकिंग इनटू समवन्स माउथ एंड आप नहीं बता रहे उस वक्त एग्जामिनर को, तो एग्जामिनर कैन नॉट सी दैट. ठीक है, अगर आप पावर देख रहे हैं तो एग्जामिनर समहाउ कैन अंडरस्टैंड कि इसकी पावर कितनी होगी. ठीक है, अगर आप लेग रेस करवा रहे हैं तो एग्जामिनर नोज दैट. बट अगर माउथ के अंदर देख रहे हैं तो एग्जामिनर डजंट नो कि उसका यूविला डेविएटेड है या नहीं है, टंग की साइज नॉर्मल है या नहीं है, या गैग इवन समटाइम्स पेशेंट डू नॉट हैव दैट रिफ्लेक्स. ठीक है, और वो हल्का सा गैग आता है तो यू हैव टू मेंशन दैट कि वो पॉजिटिव है या नेगेटिव है. सिमिलरली लाइक रिफ्लेक्स भी हो गया या फंडोस्कोपी की फाइंडिंग्स होगी, यू हैव टू मेंशन इट वंस यू आर डन और व्हाइल यू आर डूइंग इट. These two differential are always there when there is short history. तो इसको आप कभी भी आई मीन मिस ना करें, ये इंपॉर्टेंट है. ठीक है, अपने डिफरेंशियल में रखें, कहीं नहीं जा रहा. आप यू कैन say that I will keep this differential lower down the list but I will keep it. ठीक है, so आप exclude नहीं करते डायरेक्टली इसको. Similarly going to radiology, और अगर आपको कोई एक व्यू दिया है, समटाइम इट हैपेंस व्हेन यू आर डीलिंग विद शॉर्ट केसेस, वहाँ पे टाइम कम होता है तो एग्जामिनर ऑलरेडी प्लेस किए हुए होते हैं उन्होंने, तो वो आपको दिखा रहे होते हैं. बट इफ देयर इज डिफिकल्टी इन डायग्नोसिंग समथिंग, यू कैन सिंपली से कि यार ये आई विल नीड अनदर व्यू और अनदर इमेज टाइप टू डायग्नोज इट और मेक इट आई मीन श्योर. ठीक है, तो वो आप कह सकते हैं उसके अंदर. तो वो जरूरी भी हो जाता है समटाइम्स. और एग्जामिनर कभी कभी ट्रिक भी कर रहे होते हैं. दे वांट टू नो कि आपने जो है ना, वो फॉर एग्जांपल अगर कोई स्पाइनल ट्यूमर आप देख रहे हैं और आप कहते हैं यार कि जो है ना ये मेनिंजोमा है, लाइक एक्स्ट्रा मेडुलरी है. ठीक है, और आपने सिर्फ और सिर्फ सेडाइटल व्यूज देखे हैं अभी. ठीक है, तो एग्जामिनर जानबूझ के वो ट्रिक कर रहे होते हैं. दे वांट टू नो कि आप दूसरा व्यू देखना चाहेंगे बिफोर लेबलिंग इट अ मेनिंजोमा और नॉट. ठीक है, अगर आप नहीं करते तो वो नेगेटिव मार्किंग में जाती है. सो दिस इज वेरी इंपॉर्टेंट. प्री ऑपरेटिव या इंटर ऑपरेटिव जो आपने मेजर्स लेने हैं, जो टूल्स आपने यूज करने हैं, यू शुड बी क्लियर इनफ बिफोर स्टार्टिंग अ केस के जो है आफ्टर टेकिंग द पेशेंट इन ओआर माय प्री रिक्विजिट्स विल बी ऑल दिस थिंग जो भी आपको यूज करते हैं डिपेंडिंग ऑन द केस. ठीक है, वो आपने पहले से मेंशन कर. फॉर एग्जांपल समटाइम्स पीपल डू केयर न्यूरो मॉनिटरिंग की बात करते हैं और विसीएन देने के बाद बात कर रहे होते हैं कि वी विल टेक अ बेसलाइन न्यूरो मॉनिटरिंग, जो है वो बेसलाइन हम लेंगे. So that's not the idea. ठीक है, आपको पहले से बताना है कि you will have the neuro monitoring and you will take a baseline और उसके बाद you will start the case. ठीक है, अच्छा, ओपिनियंस के ऊपर बिल्कुल नहीं जाना. दिस इज द वर्स्ट थिंग टू आई मीन. बहुत से लोग हैं जो कि आपके दिमाग के अंदर ड्रिल कर रहे होते हैं ये सारी चीजें. समटाइम्स पीपल themselves are worried about these things, myths या जो डर है या खौफ है, प्लीज इस चीज पर नहीं जाना. ठीक है, ठीक है, we understand there are examiners who are difficult, there are examiners who are hard spoken, there are examiners who are tough to deal. ठीक है, there are examiners who do not care much during the exam, वो इधर उधर घूम रहे होते हैं. there are so many things. ठीक है, but जो भी है you have to pass your exam. ठीक है, आपका उस examiners का जो है वो जो मतलब जो भी चीज़ें आपका माइंड में अबाउट दैट एग्जामिनर, वो आप अपना जो है ना वो अपने स्टेशन से बाहर बाहर रख के जाए. ठीक है, जब आप एग्जाम में हैं देन यू हैव टू डील विद इट. ठीक है, आपको बहुत ज़्यादा प्रॉब्लम हो रहा है, यू कैन कंप्लेन, बट यू नो वेरी वेल कि इन आवर सिस्टम कंप्लेनिंग अबाउट समवन इज नॉट अ वेरी गुड आइडिया. ठीक है, और हाँ, पहले आप कर सकते हैं, आप कह सकते हैं पहले, बट समटाइम्स क्या होता है कि आप पूरा वाइवा देकर आ जाते हैं, फिर आप वो कंप्लेन कर रहे होते हैं, तो वो फिर इतना ज़्यादा सीरियस लिया भी नहीं जाता उसको। ठीक है। तो नेक्स्ट स्टेज के जो है वो आपको अगेन वही बात है कि जब तक एक कंसल्टेंट को ऑब्वियसली नॉलेजेबल तो होना चाहिए, ठीक है, उसको प्रैक्टिकल भी होना चाहिए। They cannot test your surgical skills in the exam, but they can test your knowledge, they can test your smartness, they can test your confidence कि अगर आपको कोई emergency scenario दिया जाए या कोई difficult scenario दिया जाए, ठीक है, या कोई difficult case दिया जाए, how confident you are talking about that topic or discussing that topic. So relax रहना है आपने पूरे उसके अंदर, ठीक है, बीच बीच में you should have some I mean क्या कहते हैं उसको, ब्रेथ अपनी वापस से आपने लेनी है, बीच में हर 5 मिनट के बाद, 10 मिनट के बाद 2 सेकंड का, 3 सेकंड का पॉज लेना है, एंड देन यू कैन कंटिन्यू योर जो भी डिस्कशन है। ये पिक्चर डॉक्टर लाल के साथ मेरी बहुत फेवरेट है, बिकॉज आई एम वेयरिंग दिस सेम ड्रेस at 7 p.m. as well, because I was very much happy to clear the exam, और मैं डायरेक्टली उनसे मिलने चला गया। So I'm just saying that this is a very short period of time जिसके अंदर you just clear your exam, ठीक है। You sometimes you are not that much confident about your exam, but you clear it because you are hitting the basic things, ठीक है। So हमेशा बेसिक पे रहना है, बाकी चीजें जो हैं वक्त के साथ वो मतलब हो जाती हैं, आप कवर अप कर लेते हैं, कुछ चीजें ब्लेंडर्स आपने नहीं करने। So this is important. So this is all about the long cases. So now I guess we can have the केस डिस्कशंस, ठीक है। एक दो लोगों ने रेज हैंड किए थे, आई एम नॉट श्योर कि कौन कौन से लोग हैं, आई जस्ट वांट टू नो कि कितने लोग हैं जो कि वो करना चाह रहे हैं, ठीक है। सो आई एम जस्ट शेयरिंग द cases now. Dr. Ali Afzal, I hope you are there with us.
Farrukh, I'm here.
Okay, so I'm just sharing the screen. So who is gonna do the first case? ठीक है। थोड़ा सा देखें, अगेन वही बात है कि आप अगर अपना कॉन्फिडेंस यहाँ शो नहीं कर सकते तो फिर एग्जाम इज अ वेरी डिफिकल्ट थिंग फॉर यू, ठीक है। ये मैं आपको बता दूँ, आई हैव बीन इन द एग्जाम एज एन ऑब्जर्वर। अगर आप कॉन्फिडेंस अपना शो नहीं करते वहाँ पे तो फिर बहुत मुश्किल होता है कि आप कोई भी एग्जाम क्लियर कर सकें। प्लीज अनम्यूट योर माइक इफ एनीवन इज रेडी टू अटेम्प्ट द फर्स्ट केस, बिकॉज हमारे पास टाइम कम है। वी जस्ट वांट टू आई मीन गो थ्रू दिस few cases. Anyone? Just unmute your mic and say, I'm ready to have that case.
Hi, hello.
Yeah, hello, Abdul Rahim, I guess. We can hear you. So,
Yeah, I can hear you. Thank you so much, Dr. Farrukh.
okay.
Yeah.
So, Dr. Ali Afzal will be, I mean,
So should I
as an examiner? So Dr. Ali, this
Yeah.
is the case. You can just, I mean,
So the important, I think, thing is the first minute is the most important minute. Whenever you have a scenario, don't jump into answering it straight away. You have 1 minute, 40 seconds,
okay.
read the scenario.
So should I take it as a talks or as a short case?
no, it's a long case.
Just
It's a long
it's a
case.
Okay, as a long case. Okay, yeah, I have read the scenario.
Okay. So based on this, what is coming to your mind?
Okay, so it seems like the case is of the cranial condition and
You will have to
supratentorial.
speak a bit loud, Abdul Rahim. ठीक है, थोड़ा सा आपको
Okay.
loud बोलना पड़ेगा।
Okay, so based on this history, it seems like the patient is suffering from some brain lesion which is supratentorial. So should I take the history?
Okay.
If you want to know Anything
Just
else apart from this,
temporal and
you can.
any other thing that comes to your mind?
Okay.
Which side?
So yeah, probably it's on the right side because the patient is suffering from the left hemiparesis, and yeah, it seems like it is in the frontal or in the parietal lesion. Might be in the temporal because seizures are there, and yeah.
Okay.
Why
And
do you
any
think
more?
this is a temporal one? What makes you think about the temporal?
Seizures are there, so seizures are more common in the temporal region. Yeah, could be in the yeah.
So, what about the other findings? Are seizures necessarily only from the temporal?
No, it's not necessarily that seizure will only be because of the temporal lesion. It could be because of the even hydrocephalus if there is, yeah, and it could be due to any supratentorial lesion. Yeah.
What can be other, lobe or area involved apart from the temporal one? Why are you leaving others?
Okay, can I interrogate a bit deeper? Can I ask some question?
Oh, one or two,
Oh,
yeah, you can.
okay.
Dr.
So
Ali
can
will
you,
help you.
okay, so can you please tell me about your headache? How does it started and how it progressed? Like for how
So
long?
headache came on suddenly.
Mhm.
It's been daily now for few months. It started 6 months ago.
Oh,
Uh, there's early morning headache with nausea.
okay. Sorry to hear that. Uh, is there any associated vomiting?
Uh, no vomiting, but only nausea sometimes when I wake up.
Okay. And you said you also had some seizures. So for how long you had these seizures, and how does it started like?
First seizure was 3 months ago. I did not
Mhm.
know what happened. My
Okay.
husband told me that he
Okay.
saw my arm shaking, and then he tried to wake me up, but
Mhm.
I was not aware what happened.
Okay. So means okay. You were unconscious that time. Does
Yeah,
anybody observe your seizure that time?
yeah, my
Yeah.
husband was there.
Okay, okay. So, what he said, it started from one side, or it was just started, or the all four limb, or it started from one side or one limb and then progressed
Yeah,
towards
it
the rest.
started from the left side and it became generalized. Okay.
Okay, good. So, yes, anything else? How is your vision? How is your vision? Can you please tell me about that?
Vision is okay.
Okay, and yeah. So, how is your hearing? Yeah.
Hearing is
Any
okay.
any speech problem?
Any particular reason to ask about the hearing in
Yeah.
this scenario?
Yeah. Very unlikely, but it could be lesion, and yes, that can develop like hydrocephalus. Yeah, very unlikely CP lesion can lead to the hydrocephalus, and the
So
patient will
that's
have
what we
seizures.
are trying to
Seizures.
make you understand now.
Yeah, yeah.
Because once
Okay.
you localize to super, because infratentorial lesions will not cause seizures. It's very
Uh,
unlikely. Even if hydrocephalus is there, seizures are not common with hydrocephalus.
yeah. Okay.
So,
Very unlikely. Okay, boss. Okay. Okay.
So
so
depending
Understood.
on
CP
this
angle.
history
Uh,
और इस history के साथ में now, what do you think? You are saying that
Mhm.
this is a supratentorial, likely on the right side, as you said, and
Yeah.
you are thinking about temporal or maybe frontal, I guess. Okay.
Mhm.
So what
Yeah.
kind of differentials are
So
there
on
in
the
your mind?
as the patient history is of 5 to 6 months, and it's like more progressive, and there is no vision or speech problem, so you probably it's some neoplastic lesion, but it could be infection, it could be very unlikely vascular malformation. Yeah, and I will keep the congenital and rest of the miscellaneous things on the bottom. Yeah, because the patient is 35 years.
Can you name a few common differentials that come into your mind depending on this history, like the neoplastic maybe, infectious maybe, congenital maybe, or anything else if you want to? Any
Sure.
five.
Sure. As the patient history suggestive of some benign or low-grade lesions, so on the top I will keep the meningiomas. It could be benign lesion like meningioma. It could be.
Name a few.
Yeah, it could be hemangioparecytoma. It could be glial tumor, low-grade glioma, and it could be tuberculoma in the infections, and very unlikely could be some maybe malformation even. Yeah.
And other glial tumors?
It could be oligodendroglioma among the glial tuber. It could be low-grade glioma, and so these are my tough differentials.
And
Okay,
vascular, you said, what did you say in vascular?
In vascular, it could be AV malformation. It could be cavernoma. It could be cavernoma.
And congenital, what are you thinking about?
And congenital, it could be some arachnoid cyst, and yes, I will keep the. And it could be some dermite, epidermite, but very unlikely.
What else is seizures? It's not the age, but I think a young patient with seizures. So you're thinking about congenital, what congenital things?
So among the congenital, as I mentioned, it could be arachnoid cyst, it could be epidermide, and it could be some.
It's one of the phacomatoses.
So it could be tuberous sclerosis, and very unlikely.
Exactly. So you think about common things first.
Yeah.
And when you're saying, so you have to think about oligo. If it's a young patient
Sure.
with seizures, the first thing you have to think about is oligo.
Yeah,
Low
thank
grade
you.
might be a
As I
differential,
mentioned,
but yeah, okay.
Yeah, I have mentioned the oligodendroglioma among my glial tumors because oligodendroglioma is one of the glioma. Yeah, thank you.
And CP angle, do you think they'll still think it's CP angle?
No, boss, I will take my word back.
Exactly. So that's the thing we're all saying, that don't try to go for a difficult diagnosis. And even if there's one finding that's going against what you think is happening, so that probably is not the answer. Okay.
Yes, of
So
course.
you cannot justify CP angle as the top differential here.
Understand.
Okay. Yeah. Okay. So what do you need next now after the history?
So after history, I would like to run for some investigations. So yeah.
Before the investigations, would you like to examine the patient?
Sure, of course, I will examine the patient, and
you have to go in a sequence, okay?
Okay. So I
first
will
they will ask you
start.
differentials on your history, then on your examination, and then you will go for relevant imaging. Okay.
Sure. So I will start from general physical after introduction and taking the consent.
You have these positive findings.
So have a look on the slide.
Okay.
Oh, the positive findings are mentioned.
Okay.
There's an error. The planter is the left planter which is upgoing. Okay.
Yeah, it's left.
Okay. The planter is the left one is upgoing. Am I right?
Yes. Yes.
Yeah. So thank you very much. I have read the examination findings. These are so based on these findings, I believe that the patient is having some supratentorial lesion, probably at the right side.
Okay. So what do you want to do next?
Can you localize it further?
Yeah, it seems like in the frontal lesion, in the frontal lobe.
Frontal is a big lobe. So
in the right frontal lobe, probably near the motor area, because the patient history was consistent with the generalized tonic-clonic, because it was started as a focal seizure and secondary generalization was there, and there is also the power is reduced in both the upper and lower limb.
Any important
Yeah.
examination finding you want to ask? Any apart from this? अगर कुछ है mind में तो you can ask and then we can talk about the differences.
So the mini-mental score is low, that is 20. So I would like to ask about the behavior of the patient and any urine incontinence.
No, you cannot go back to the history
Okay.
part. Okay, ये आपको understand
Okay.
करना है. Okay.
Okay. So further, I would like to ask about the parietal examination. Like I would like to see for the Gerstmann syndrome.
That's normal.
Yeah, okay, that's normal. Any like alexia, agraphia, or sensory
Any important
disturbance.
thing you are missing here, which is not
Any-
mentioned in the examination.
Okay. How is the fundi?
Yeah, that's what we would like to ask on the first thing. Now, बाकी चीजें आप already mentioned. You will be asking about the fundoscopy. There's mild papilledema on the right side. Okay. So
On
now
the
what are
right
the
side-
differences now?
On the right side, there is papilledema, and what's there on the left side?
It's normal.
That's normal. And what's about the sense of smell of the patient? Is there any anosmia?
No, it's not there. Okay.
Uh,
now,
so-
Clear nerves are intact.
yeah,
What
it's
you could
mentioned
also
there.
have pronator drift, but okay.
Okay, the
Okay.
pronator drift is on the left side or on the right side? Can I know?
It's on the left.
It's on the left side. Okay.
So Abdul
So,
Rahman, you need to be clear now whether you are thinking of
Yeah.
skull base
No,
or
boss.
you're thinking of
Yeah, unlikely,
a
very
lobar lesion.
yeah, it's a lobar lesion, probably on the right frontoparietal region. I
So
would
what are
not
your
say,
top three differences now after the STEM examination?
yeah. So again, neoplastic lesion, some benign lesion could be convexity meningioma, and could be low grade, unlikely would be low grade glioma.
Why unlikely?
Because the upper limb and the lower limb is involved in the homunculus, so it could be, but yeah, and could be tuberculoma even.
Okay.
Okay. So
ठीक.
what
So
else
what would
then?
you like to do now?
So both I would like to go for the CT brain with and without contrast to see, or first I can go even for a plain
Okay.
CT.
Okay, now
thank
you have this now because
Yeah,
अगर थोड़ा
okay.
time कम है, so we will
Okay.
need to move faster. Okay.
Okay.
So
Okay. So
And the
thank
other
you so
thing is that if it's an acute scenario, तो CT makes sense. If it's
Yeah,
not an
yeah.
acute scenario, तो
No,
but CT can help you rule out a vascular
Yeah.
bleed or something if
Okay,
you
of
want
course.
to justify it. Okay.
So,
So please describe the imaging.
okay. So there is a single, well circumscribed and hyper intense homogeneous contrast enhancing lesion with a broad base dural tail, and it is single, and it's originating from the right convexity, and having mass effect on the surrounding brain, and there is a significant edema and midline shaft toward the contralateral side, and some subfalcine herniation I can appreciate. Yeah. So.
so
Yeah.
lesion is very obvious, I guess. And so now, what is your diagnosis now?
Yeah.
What is
So,
your differential now?
So based on these radiological feature, I would say it is the convexity meningioma. Could be hemangioparasitoma. Yeah, these two are my top differentiators.
And third differential?
Very unlikely. Very unlikely. It could be some dural mets.
Yep.
Yeah.
So now, how will you manage this patient now?
So after counseling the patient in a compassionate way, and I would describe as the patient is symptomatic, so I would optimize the patient for surgery. Definitely, I need to go for some baseline investigation, yeah. And after that, I would counsel the patient regarding the surgical options and the risk and benefit ratio, and later on, what to do
The,
post-op.
the patient wants to know about other treatment options and if they are applicable.
Yeah, so based on the clinical history, examination, and the radiological signs, uh, the lesion is quite significant, sizable, and it's superficial, and it seems like benign. So I would offer for surgery. Before surgery, definitely I will ectomize. I will give some anti-seizure medications, some steroids, and yeah. And after that, I would prepare the patient for surgery. My first suggestion would be for surgery, to go for surgery. In this case, yeah.
Okay, tell us about the surgical approach and the steps quickly, yeah.
Yeah,
So
sure.
we can rewind it.
Yeah,
Right.
so I would go for the right horseshoe craniotomy. So after okay, uh, after optimization, I would shift the patient to the OR and uh, uh, will arrange everything before starting the patient, the neuronavigation, the microscope, and all. Okay, as the lesion is meningioma, so I would also arrange the blood, and before that, as the lesion is near to the motor cortex, so I will also arrange for the neuromonitoring, for up neuromonitoring, and
What
then
kind of
after.
monitoring will help you?
Yeah, so in this case, the MEP, the DCCP will also help me. But if we do have the facility of the motor mapping available, so that would be much better.
Okay, go on.
So after placing the patient in the supine position while turning the head to the contralateral side, I would mark the incision, and under general anesthesia, I would make a horseshoe incision, try to make a big craniotomy because the lesion is the lesion is meningioma.
What's the principle of meningioma surgery?
So the white craniotomy, and there should be devascularization, debulking, and delineation. Yeah, and not to violate the margin of the lesion, not to traumatize the normal brain, and to keep the arachnoid plane. Yeah,
And what
and to
kind
do
of
maximal safe resection. And this I would try to go for gross total resection, including the removal of the hyperostotic bone and the involved dura and everything. I will do Samson. If the facility, the gadgets are available, so I will try to go for the Samson 5 removal.
So you
Sorry,
will leave the patient with a large connectomy defect?
No, boss. I will
You said
try
Simpson
to.
5, did you?
Sorry, sorry. Samson 1. Samson 1. Yeah.
So what's the difference between Simpson 1 and 0?
Yeah. So in Samson 1, we remove everything. Microscopic gross total resection, including the bone, the dura, and yeah, yep. This is Samson 1.
Is there a difference between 1 and 0?
Sorry, I'm not sure. I haven't heard about 0.
And what's the histological grading for meningiomas?
Histological grading could be grade 1, 2, and 3. Yeah.
Okay. And complications?
The complication of surgery, so yeah, definitely the general anesthesia complication, including the MIE and the stroke, and yeah, And after that, the surgery complication, Farrukh complication, and then later on complications. So Farrukh complication in this case, as the lesion is near to the motor cortex, so there could be monoparesis or could be hemiparesis or hemiplegia if somebody violate the margin, and there could be seizures later on, and hematoma, definitely blood loss, and infection later on. Patient can develop hydrocephalus. C-SIP leak, very unlikely, and wound complication, and recurrence even failure.
What are the chances of recurrence in this case?
So the chances of recurrence again based on the histological grading and how much we
No,
resected.
for example, this is a grade 1. That
Okay, so this is a grade 1. Then depends upon that which Simpson we have resected. Simpson 1, 2, 3.
as you said, you want to achieve the 1. So what's the prognosis?
So that is sorry, exactly I forgot, but seems like up to 9%. Yeah.
Okay.
And you said you will take the bone out. So will you replace the bone defect with something? Will you counsel for it before, or will you do it a few months after surgery?
Yeah, later on, if there was significant cranial defect, I can do interval. Even on the spot, I can do the early cranioplasty in the same setting, and later on, I can do interval cranioplasty.
What will be the considerations? क्या क्या सोचेंगे आप if you are thinking कि आपने cranioplasty भी करनी है at the same time?
Okay, so I would see the status of the bone, and will also prepare all the things
You are
before
removing the
starting my
bone.
surgery.
You are
Yeah,
already
so
removing the bone. So
okay,
you will have the normal bone around the defect.
exactly. Yeah. So the size of
Anything important you can see on the scan that will be, I mean, the troublesome thing if you put it.
So boss, actually, I could not. I haven't. If the CT
No,
scan is
not about
available.
CT. Okay.
Okay, there is no CT scan. Okay, so then I cannot properly comment on the bones that how much hyperosmosis is
Can
there.
you answer one more thing? Would you consider going for an awake anatomy in this case?
Yes, definitely. If the facility is available, I would go for the awake craniotomy, and that is the best option, I believe, in this case, because it's near the motor step.
Dr. Ali Afzal, what's your comment on the awake anatomy?
This is a convexity meningioma.
Sorry. I will take my word back, because the lesion is extraaxial, and yeah, the lesion is extraaxial. So if we keep the principle, and we are in the limits of the meningioma surgery, we do not. Yeah. So sorry to say, I would definitely take my words back. In extraaxial lesion, there is no significant role of the awake craniotomy.
No. What if you had the same patient with the same clinical and examination findings, but a glioma, like 2.5 centimeter, 3 centimeter glioma?
Then
Would you still
definitely,
go? Huh?
then in the intraaxial lesion, definitely I would go for the awake craniotomy if the facilities are available.
I will still not go for one reason, and that is that the patient's minimeter score was 20.
Oh, sure, boss.
Okay,
So
you will
sorry.
have to take that in consideration कि आप उसको देखना पड़ेगा कि patient is understanding the things or not. So वो आपको बहुत ज़्यादा assessment करनी है कि उसके अंदर. Okay. So I guess we
The
are
other
done with
thing
this
is that
case. Any comments? Yeah, Dr. कुछ comment कर.
The other thing is that it needs to be near the motor cortex and its dominant side. Neuromonitoring is not for every tumor or lesion. So it has to be intraxial near the motor cortex, and when especially you can ask for other information as well when you're going for it. Like Farrukh mentioned, MMSC is important, and then where you have the DTI and other mapping as well to help you. In the exam, you're supposed to think you're in a good setup with all the facilities. You're not going to be in a BHU operating on a meningioma or a eloquent glioma. So it's important. The other thing is that you have to think about before starting if you're going to take the bone off or not. Whether you need to take the bone off. This is a post-op complication that you might need to take the bone off post-operatively, and because of the edema that's already there on the scan. So that's something to think about. It's useful to know all the adjuncts, but you have to be very careful in your selection whether you're going to do something or not. Okay. Um, so
Yeah,
that is
you
why.
have said about the क्या कहते हैं आप उसमें न्यूरो नेविगेशन की बात you can say that similarly you can go for CUSA, ठीक है, those things are important in this case. In cases, I mean, the large tumors उसके हम आप वो कर सकते हैं, but going for neuro monitoring in such a case will be very difficult.
And you'll go unnecessarily into questions that will not gain you marks and become negative. That is why it's important to finish on time, have time to summarize your case, and think about the operative steps beforehand. And I
Suppose,
think
can
just
I
as a
ask?
comment, just as a comment that when you're localizing, so you can only make one or be close. You can't think about CP angle if you have a supratentorial lesion, and you have to explain you don't have any lower cranial nerve involvement at all. You've got CP angle is far away from the motor descending tracts as well. So you have to be very careful. Look at the scenario, look at what the patient is saying. Once you commit, then some examiners will not give you any leniency. Very few examiners will let you come back to zero again. So be very, very careful. Even if you're doing talks, it's very important that you look at what the scenario is saying, you localize it well, and then stick to it. As Asad said, they'll just test your confidence, whether you're sure or not. You're not blind guessing. So stay on what you have said, and if there is one or two things that are not making sense, then what you are localizing is probably not correct. जज्बाती होने की जरूरत नहीं है. Take your time, but once you make a differential or a diagnosis, then stick to it. And you should have the supportive evidence. That is why you need to finish your history and examination on time, so you can summarize your findings, and you have time to go back to the patient. If you still have 4 or 5 minutes left, you missed something, you can go back. You forgot to do the fundoscopy, go back and do it. You forgot to check the planters, go back and do it. You forget to check. Please tell me what you would like me to do. You forgot to check for proptosis, go back and do it. Like, you have to make sense. CP angle, skull base, there are certain giveaways. Skull base में cranial nerve involvement जरूरी है. If you have a skull base lesion, patient should have some cranial nerve deficit.
Yeah, of course, sure.
ठीक है ना? So it's time to get your knowledge applied. आप the theory निकाल लिया, you have the knowledge. Application is very important now.
Yeah, I guess we can do another case.
So thank you very much. Thank you.
Thank you, Abdul.
Okay. So who is gonna do the next case? भाई it will ये बहुत मुश्किल हो जाएगा कि अगर आप लोग खुद से नहीं आएंगे, फिर हम किसी का नाम लेकर कहेंगे तो इट डिफिकल्ट के वो फिर जो है वो माइंड भी कर सकता है कोई बंदा. सो इट्स बेटर दैट यू गाइस कम अप. आपने देखा बिल्कुल सिंपल केस है, आज फर्स्ट डे है, सो वी आर स्टार्टिंग विद द वेरी सिंपल केसेस ताकि थोड़ी सी
The other thing
डिस्कशन हो
is
जाए.
कि यहाँ गलती कर लो या अपने वार्ड में जो केस प्रेजेंटेशन है उसमें आप गलतियां कर लो. They will help you in the final day. अगर यहाँ गलती करके एग्जाम में तुम लोग पास हो जाते हो तो दैट्स व्हाट दिस इज अबाउट. मुझे और फरूक को एग्जाम पास नहीं करना. हमारा नॉलेज जितना भी अच्छा बुरा था, we satisfied the examiners. So I presented to Dr. Juma a lot of times. I think 80% of the time I failed in front of him. But every step is a step. It brings you closer to your goal. तो criticism का अगर कुछ है या कोई points हैं तो वो आपके just help के लिए है. So just don't be shy or
Yeah. Anyone? कोई भी एक बंदा.
I can go for a second case if you allow.
No, I don't think we should continue with the second case. कोई और आना चाहिए. Otherwise, we can just. I mean,
randomly
I
pick.
can
Yeah.
scroll through the cases. I can just
Yes,
discuss
I am ready.
things, but वो idea
I'm
नहीं है.
ready.
Yeah.
Yeah, I'm also ready.
I guess Manik
Hi.
is there. So
Yes.
yeah, Manik, we can take you for the next case. I hope you are ready. Okay.
Okay.
So this is the second case. You can read the scenario. And then if you need any more history points, you can just simply ask. We're not talking about the detailed history here or the detailed examination, but a few points you can that can help you diagnose this case. Okay.
Okay. I'll ask about the onset of pain, duration, and radiation of pain. Is there any to the left or right side or anywhere?
It's
Yeah, so
already
the pain was
mentioned.
gradual. Yeah, gradual onset. Start with the lower neck pain, and then it's limbs pain started as well about 3-4 months ago. Sensory changes are there as well. The
Is
pain
there
was
any?
gradual onset and it's become severe now.
I'll ask more about, is there any aggravating or relieving factor for neck pain?
Sometime when the patient strains, the pain becomes increased.
Mhm.
Or
Did she
when he
try any medication or any other treatment to relieve her pain?
he has been going to local doctor, but the pain is just increasing over time. It's not getting better.
Okay. Does this associated with any numbness?
Yeah, there are sensory changes both in his arms and legs.
Mm. And is there any association with the weakness of lower limb?
No.
Patients sometimes feel that his balance is not good, but there's no obvious weakness. He can still walk without support.
Any bowel or bladder changes?
No.
Does the pain occur more during nighttime or daytime? Any specific time?
It's there all the time. There's no specific time to it.
Does he have any contact history with the patient with the tuberculosis or any patient member in the family with the TB?
No. He
Any
doesn't
history
have
of
any weight loss or anything like that. So what comes in your mind now after taking this history?
most likely there is some lesion in the cervical, high cervical region that could be degenerative, which is less likely in this age group. Neoplastic infective is the first thing in my mind.
What else? Look at the age of the patient.
He's 25 years old and more upper
So young
and
patient
lower.
with neck pain.
Most likely cervical discs.
In a young patient again. It can be very, it's not common. What do you think if there's a patient less than 25, 30 years of age? What sort of lesions could you expect or pathologies?
Like cranial malformation.
Exactly, that should be the top differential here.
Mm-hmm.
I did give you a clue in the pain as well. You asked for aggravating factors.
Yeah, I just missed that.
Especially when the patient is talking more about the sensory things rather the motor things. So
And
Yeah.
you ask for aggravating factors. Would cervical disc have aggravation with cough or straining?
Not really.
Exactly.
Cough. Yeah.
So again, the age is very important. This is
Mm-hmm.
if there's a young patient, you have to think about congenital issues. Okay.
Yeah.
If the patient says his age is 25 and he looks like 16 years of age, so what do you suspect? You have to suspect, okay, maybe he's got a pituitary lesion.
Mm-hmm.
He's got, you know, hypopituitarism. He looks
Mm-hmm.
16 years old. He is 20. So age is very important. And then when you are asking specific questions, then it means that you're localizing the pathology and you're trying to find out exactly the nature of the headache. So if there's a
Mm-hmm.
Valsalva-induced headache,
Mm-hmm.
then CVJ, you are thinking about CVJ. There's no other thing to think about. It's a very
Mm-hmm.
specific question, like early morning headache and nausea,
Mm-hmm.
nocturnal pain on lying down, specific question. Again, this is specific for Chiari. If there's a Valsalva headache, top differential becomes Chiari.
Mm-hmm.
You can justify other differentials, but again, as you said, degenerative changes in a young patient can be there on a background
Mm-hmm.
of congenital stenosis. If the patient has a narrowed cervical canal, and then usually there's some antecedent trauma, then sometimes they can represent with features of cord. But again, as Farrukh said, there's sensory changes more, and you've also asked a relevant question here about the
Mm-hmm.
trigger factors.
Mm-hmm.
So you can always also think about neoplastic and other things as well.
Mm-hmm.
Okay, uh, so you're localizing the lesion to high cervical cord, CVJ. We don't have any obvious symptoms of post fossa or lower brainstem cerebellum. Uh, but I think you can at least go up to the CVJ if you're not going up to the brainstem or post fossa.
Mm-hmm.
So what do you want next now?
I would like to get X-ray followed by MRI of
What do you do after
craniocervical.
history?
I would like to go for physical examination.
Exactly.
Mm-hmm.
Farrukh, can you share the examination?
So just give me a minute or so. Yeah, जो है disconnect हो गया था. I'm just bringing it down. Just okay. So these are the findings.
Okay. Yeah, I can definitely see there's some motor weakness and dissociative sensory changes, more likely consistent with craniocervical abnormalities, likely carry.
What else will you look for?
I'll look for any signs of hydrocephalus.
Examination, you're on examination now. So what will tell you about hydrocephalus?
I'll do fundoscopic examination.
Okay, fundoscopy is normal.
And then what else?
This is just some examination. You can ask for other specific questions for the examination. So if you're localizing the patient to CVJ, what is the classic findings usually you see in Chiari patients as well?
Down with nystagmus. I look for yeah.
Yeah, you can have nystagmus and you see the hands if there's any hand wasting. That's
Mm-hmm.
very important.
Hand
So
wasting.
And then
Signs of.
hyperreflexia clonus.
Mhm.
So that's very important because these patients can have this. These are classic findings. If you have a young patient who's got hand wasting and neck pain, then it's most likely Chiari. The other thing is you can check for specific dermatomal distribution if there's anything that can help you localize if you're thinking about a disc or brachyalgia. But disc usually you will have unilateral findings rather than so it normally should be brachyalgia one-sided, very rarely uh, on both sides. So again, that would go against a disc, and the disc prominently very rarely will affect your sensory columns.
Okay, I guess we have 5-7 minutes to finish today's.
So what do you want to do
session.
next now? What imaging do you want?
I'll do MRI of craniocervical junction, including the brain.
Okay.
Okay, you have this MRI. I mean, these are the only images you have. So,
Can you describe them quickly?
Yeah.
These are two images. First one is a T2 weighted sagittal image showing craniocervical junction, where we can see there's hyperintense lesion in the cervical spinal cord. I can't see it whether the posterior fossa is crowded or small. I can't comment on that.
So
I
you have
can
the
see
image
on the right side, definitely there is a descent of cervicomedullary junction below the foramen of magnum with the slanting of tet. And there's no
Okay.
obvious, yes, that's it. That's the only thing I can see. And
what can you? Yeah.
hyperintense signal in the cord, most likely syringomyelia.
Okay. So what's the different diagnosis now?
So this is most likely Chiari a type 2 with the syringomyelia, type 1 with syringomyelia.
Yeah, you can't say type 2 because this is not a
Yeah.
young. There's no evidence MMC. You don't have lower spine images.
Yes, type 1 with syringomyelia, sorry.
And what's the difference between hydromyelia and syringomyelia?
If it's extended beyond the medullary, that's I'm not sure. I don't know the difference.
Okay. So as we are short on time, what's your management plan?
After optimization, I'll counsel patient about the treatment options, as he already has symptoms. So he would benefit from doing surgery to arrest his symptoms and stop the progression, as well as relieve his pain. And after optimization, I'll plan for suboccipital craniotomy and decompression of posterior fossa with the lax duroplasty.
Okay, what are the other options? Not
Uh,
necessarily in this case, but what are the other options for such a case?
We can observe and repeat MRI, but he has the symptoms and
Okay. So what is your extent of cranectomy or bone removal?
3 centimeter above the foramen magnum and 3 centimeter in diameter.
Including the foramen magnum or above the foramen magnum?
above the foramen including the foramen magnum.
And what about C1, C2?
Uh, if needed, I will do C1 laminectomy as well.
What will make you need it?
Depending on the herniation of tonsil below the foramen magnum.
Okay, so what is the landmark and how do you define the criteria for Chiari? Do you know
Uh,
the lines or the landmarks?
Yes, McRae and Chamberlain's line are most commonly used
So what's the
lines.
McRae from where to where?
It's from the Bayesian to Ophistian.
And how what's the cutoff for the tonsillar herniation?
But more than 5 millimeters below the.
Okay, so the tonsils are only herniated. So what's your indication for C1 removal?
If we have done intraoperative sonography to see whether the CSF flow can be noted,
Okay,
then probably.
and what's your indication for duroplasty?
If there is a obstruction of CSF flow in the craniocervical junction, then definitely we'll need to do duroplasty.
Okay, so which sequence helps you with that?
Cine MRI or T2 sequence most.
And you already have a sizable syrinx, so what do you intend to do about it? Would that affect your judgment of doing a C1 as well?
Definitely, yes.
So standard, no, you would probably take C1 normally with post-fossa decompression because there's already a lot of crowding. There's a sizable syrinx.
Mhm.
Even if you use ultrasound, I think you'll find it's very narrow and tight. So probably you will end up doing an expensile duroplasty and take the C1 arch as well.
Yes, generally it's considered the part of the surgical treatment for Chiari that along with the posterior decompression, you will have to take the C1 laminectomy.
Yeah.
So generally we do that. Duroplasty is another
Some
thing.
people go down to C2 as well, but very rarely.
Yes.
And you don't want to normally touch C2. Why is that?
And duroplasty is for the CSF flow and also for the overcrowded posterior fossa, just to increase the size of that thing as well. And sometimes you have to look into the tonsil as well. Okay, is it mobile or not? वो आपको देखनी पड़ती है sometimes, ना? So it's necessary that in such a
Some
case.
people do only bone-only decompression. Some people will do a durotomy and duroplasty because sometimes you have to open the arachnoid webs and look into the fourth ventricle to make sure that there's a good CSF flow. And some people will also cauterize the tonsils. Most of people will not. Okay.
So what will be your goal? I mean, what will be your plan for the syrinx? It is going up to the mid dorsal. It's in my own case. I operated this patient, so so I know very well that it's going down to the mid dorsal level. ठीक है, और इतनी ही large. I mean, it's large enough. But the patient was quite well. He was mobile. He wasn't having any major deficit. ठीक है, sensory changes and sensory problems are there. So, what will be your plan for the savings mode?
I think he has no motor deficit, so I will. Most of the time, we can go for subarachnoid seeing shunt, but
So you're operating on the patient. Will you do it in the same setting?
Yes.
Okay. What is the general principle for Chiari surgery, even if there's a syrinx? The first thing is you relieve the obstruction because I think we're short on time, but you'll eventually be asked the theories for syrinx formation, okay? And one of the first objective is to relieve the pressure on the CVJ. Once you open up the CSF flow, it should take care of the syrinx. So you never touch the syrinx on the first setting, okay? If you've done only bone only decompression, the second time you do a duroplasty, and you see for any arachnoid scarring, and make sure there's good CSF flow and do an expansile duroplasty. Even after that, if things are not working, syringe is getting worse and the patient is getting worse, then you think about syringe to subarachnoid shunt. You'd never straight away jump into doing anything with the syrinx. That's a very important thing. The other things are there are a few theories associated with this. Do you know any of the theories?
Yeah, one of them is Gardner's theory, another is Ball-Ryan's theory, and another is Waterhammer theory.
Exactly. So you need to know all of this. The other thing is whenever there's a young patient with any pathology, you ask for the whole neural axis MRI. So even if you're given limited cuts, as Farrukh said, you can't see the lower extent of the syrinx. So you have to ask, do we have any? Because there are a few things associated with Chiari malformation. There might be vertebral segmental defects, clipal fail, something else going on as well. That's why you need a whole neural axis MRI. Never compromise on your imaging. And these are things now because you're hoping to become a consultant. So they will expect you to be very clear. Your management should be crystal clear what you're going to do, how you will do it, and what complications can happen, and how will you manage those complications. Okay. What are possible complications from this surgery?
One of the complications related with the Chiari surgery is early respiratory depression leading into mortality. And second is wound infection leading into meningitis. Third is pseudomeningeal.
Respiratory compromise is not common. It's more common in children instead of adults. It's not something common because unless you've gone into the fourth ventricle and then you've had a mishap, it will be very surprising to have. So wound issues, pseudomeningeal, then hydrocephalus, infection, need for repeat surgery, vascular injury. What vessel can you damage?
Vertebral artery and pica.
Which is more common?
Vertebral artery.
Would you hit the vertebral artery normally in your exposure?
Usually not.
Which vessel is close to the tonsils?
Pica.
So yeah, we all think vertebral artery is common. Pica is more common. People can have a pica-related stroke. Usually, it's tolerated well by the patient, and that's usually when you're doing opening the dura and you're trying to manipulate the tonsils. That's when you can normally see it under the microscope, and that's what you need to avoid damage to. Okay. Vertebral artery is not a common. You should not be exposing it in a Chiari normally. But if you're going lateral enough and you might sometimes hit it, then it's possible. But common pica is common. Okay, vertebral artery is not common.
So I guess we need to close it down. And once again, I would like to thank Dr. Ali Afzal and all the other presenters and also the candidates as well, especially Dr. Asad Abbas. He was busy. He gave time, Dr. Rabail, Dr. Tanweer as well. So any last comment from you guys? I mean, आप लोग सिर्फ observe ही करते रह जाओगे. Yeah, you will participate into it because over the next 4 days, if your participation is not good enough, so it's not gonna help you or me as well. Okay. So the thing is, we want these sessions to be as interactive as possible because only then you can improve your skills and your talking ability or your differential, whatever we are talking about. So important है कि आप बात तो करें at least ना. So कोई भी और किसी ने कुछ सवाल करना है तो if you can put your question here or I will ask Dr. Ali Afzal to give the last comment and then we can just end this session. Dr. Ali, if you want to have last words for the day. I guess so.
Thank you for the opportunity, Farrukh. I know it's a difficult time, it's a stressful time. Lekin, as I said, you have to now be selfish. You have to plan. You have to identify your weaknesses. Uh, Pakistan, mein, it's not supportive environment. I think still people talk about legends, but grooming, mentoring, and encouraging, questioning, presentations. That's still, I think, quite a way behind. But you have to prepare yourself. If you think you want to be a consultant, then you have to show it. Your decision making should be clear. Your concepts should be very clear. Otherwise, the examiners will be able to trap you easily. हमें एक बहुत अच्छी जो एडवाइस हमारे सीनियर दी थी कि you have to be very humble in the exam. You have to be clear. You have to have very clear concepts, and they won't let you become a consultant that easily. You have to show that you are deserving. So ये सेशन है या कोई भी सेशन है, we are not here to judge you, we are not here to embarrass you. We are here to support you. Anyone who knows me या Farrukh, ये सब, I know them very well. We are all here to help you out. We can take out time, we can guide you, but you have to eventually do it. So you have to use the opportunity to present. ठीक है? There are people who have now become faculty members. I know they took my sessions as well. Uh, they failed one exam, but they will to do it in the second attempt. So failing is not uh, something that is going to black mark you. The examiners also will not remember who failed, who passed. They see too many people, too many patients all the year round. So don't think that someone is targeting you. Lekin, as you see in this 2 or 3 questions that we have done, we just touched the surface on some of the things. So a lot of things that can be asked, but there are some fundamental concepts. If you're localizing something, you need to be very clear. Skull base है या नहीं है? CP angle है कि नहीं है? Lobe, upper lobe है, supratentorial है, infratentorial है. This is the time. तो अब अभी 1 महीने से ज़्यादा है. Use that very positively. कोई भी issue है, कोई भी काम है, I've shared the outlook के जो भी topics covered हो सकते हैं. एग्जामिनेशन में जो एक proper practice होती है, और एग्जामिनेशन के एंड में एक MMC का भी आपको एक फॉर्मेट बना के दिया हुआ है, हाउ टू एग्जामिन MMC और व्हाट टू लुक फॉर. तो यूज दिस वाइजली. अपने कॉन्सेप्ट क्लैरिफाई करो. एग्जाम से बिल्कुल बहस नहीं करनी, रूड नहीं होना वहाँ पे पेशेंट से और एग्जामिनर से. बिल्कुल प्रोफेशनल आपने बिहेव करना है. गलती हो जाती है, एक दो फाइंडिंग्स भी मिस हो सकती हैं, बट अगेन इफ यू गॉट टाइम यू विल रियलाइज इट के मैंने पैपुलोडीमा चेक नहीं किया, मैंने प्लांटस चेक नहीं किए, मैंने पेशेंट को वॉक नहीं कराया. कुछ चीजें ऑब्वियस है. पेशेंट ऑलरेडी ब्लाइंड है, एक्रोमेगली थी उसको, या पिट्यूटरी ट्यूमर है, या कोई भी उसको
टेंट मिस कर
ट्यूबरकुलोसिस.
जाते हैं, बहुत सिंपल सी चीज है.
तो ब्लाइंड पेशेंट को यू डोंट नीड टू मेक हिम वॉक कि नहीं मुझे इसको जबरदस्ती चलाना है. वो पेशेंट ऑलरेडी ब्लाइंड है, ही नीड सपोर्ट. तो कुछ क्लूज आपको ऑब्वियस विजिबल होते हैं. तो आई होप दिस रिव्यू कोर्स हेल्प्स यू ऑल. गुड लक. कोई भी सवाल हो तो आप पूछ सकते हो, लेकिन दिस इज द टाइम के यू हैव टू गेट आउट ऑफ योर कंफर्ट जोन. थोड़ी थोड़ी चीजें होती हैं, छोटी छोटी चीजें होती हैं जो अभी टाइम है वो आप कवर कर सकते हो. एक ही चीज को पढ़ पढ़ के कोई फायदा नहीं है. ऑल दैट नॉलेज नाउ नीड्स टू बी अप्लाइड. You have to apply it on patients, on radiology, on theater. थिएटर में जाओ, डायग्राम्स बनाओ, अप्रोच को देखो, लैंडमार्क्स टू टारगेट पकड़ो. ये सारी चीजें एग्जाम में ऑटोमेटिकली निकलेंगी. फिर एंड टाइम पे अगर आप सोचोगे कि मैं लास्ट डे में ऑपरेटिव पढ़ूंगा सारी, इम्पॉसिबल, कैन नॉट हैपन. अगर आप थिएटर नहीं जा रहे थे और आप ऑपरेटिव टेस्ट भी नहीं पढ़ रहे थे, आपके पास एटलसेस ओपन नहीं थे, आपने मॉडल्स नहीं देखे हुए, तो उस वक्त फिर बहुत मुश्किल होगी. एग्जामिनर्स के पास नॉलेज भी है, एक्सपीरियंस भी है, उनको आप मैच नहीं कर सकते. ठीक है, बट दे देयर टू हेल्प यू. कोई आपके अगेंस्ट नहीं है. यूज ऑल दीज टाइम वाइजली. अगर आपको और सेशंस करने हैं मेरे साथ तो फरूक कैन आस्क मी, आई कैन डू इट. फरूक आई थिंक खुद भी अरेंज कर रहा है, तो टेक ऑल दिस पॉजिटिवली. यहाँ 100 गलतियाँ हो जाए कोई मसला नहीं है. नो वन विल रिमेंबर. हमसे भी वो गलतियाँ हुई, मैंने तुम्हें खुद बोला है. डॉक्टर जुम्मा के सामने 80-90% टाइम्स आई फेल्ड, और बाकी उसमें हम कामयाब भी हुए. लेकिन द आइडिया इज यू हैव टू कम आउट ऑफ योर कंफर्ट जोन, प्रेजेंट, और अब टाइम है कि अपना नॉलेज सॉलिडिफाई करो, अपने कॉन्सेप्ट क्लैरिफाई करो, यू नीड टू बी वेरी क्लियर। और जो स्पेशल हिंट्स हैं, पैथोग्नोमिक साइंस हैं, वो आपको पिकअप करने हैं। इज इट मेकिंग सेंस? यूनिलैटरल पैथोलॉजी है, इज इट समथिंग दैट्स एक्सप्लेन द बायलैटरल पैथोलॉजी या क्वाड्रिपरेसिस? तो थिंक अबाउट इट। जितने केसेस हैं वार्ड में, अपने जितने भी एग्जामिनर्स आपके डिपार्टमेंट हैं उनके पीछे पड़ जाओ कि वो तुम लोग के सेशंस लें, उनके साथ वार्ड राउंड्स अटेंड करो, उनके साथ केसेस देखो, उनसे टाइम निकाल के कहो कि सर आई लाइक टू प्रेजेंट अ केस टू यू। एक दिन उनसे ले लो हफ्ते में, फ्राइडे ट्यूसडे जो भी है, जहाँ वो अवेलेबल होते हैं और तुम लोग के केसेस देख सकते। दे विल हेल्प शाइन यू, दे विल हेल्प पॉलिश यू, और इंशाल्लाह यू ऑल हैव द नॉलेज, यू हैव क्लियर द थ्योरी। तो नॉलेज तो है तुम लोगों के पास, यू नाउ नीड टू अप्लाई इट। और एज फरूक सेड, फाइनाइट नंबर ऑफ केसेस हैं, उस पे आपको ये अप्लाई करना है। और जितना क्लियर आपका कॉन्सेप्ट होगा उतने अच्छे आपको आगे भी लाइफ में हेल्प होगी डिसीजन मेकिंग, क्योंकि नाउ यू आर कंसल्टेंट, यू आर डिसीजन मेकिंग एंड एंटिसिपेशन ऑफ कॉम्प्लिकेशंस। और वही आपकी एक प्रिपरेशन होती है थिएटर में भी, कि ये चीज़ें मुझे चाहिए, ये चीज़ें पॉसिबल हैं, ब्लड की ज़रूरत पड़ सकती है, इस केस में न्यूरो मॉनिटरिंग की ज़रूरत पड़ सकती है, फेशियल नर्व मॉनिटरिंग की ज़रूरत पड़ सकती है, अगर आप ALA यूज़ कर रहे हो, इंट्राऑपरेटिव न्यूरो मॉनिटरिंग है या मैप मोटर मैपिंग है, ये सब आपकी एडजंक्ट्स है। तो अब इस तरह सोचना शुरू कर दो, फॉरगेट कि अब तुम रेजिडेंट हो, फॉरगेट कि तुम थ्योरी पढ़ रहे हो, इट्स ऑल प्रैक्टिकल नाउ। क्लिनिकल एग्जाम है, यू हैव टू प्रिपेयर अप्रोप्रिएटली, ठीक है? और इट्स पॉसिबल। अभी आपके पास मोर देन अ मंथ है, अपने सबसे पहले ट्रैवल लॉजिंग का अरेंजमेंट सॉर्ट करो। आई डोंट थिंक सब कराची के, गेट हियर इन टाइम, डोंट लीव इट टू लास्ट मिनट। अपने लिए लैब कोट ले लें प्लीज, अपने सारा इक्विपमेंट एक बॉक्स बनाएं, स्टार्ट यूजिंग दैट बॉक्स, ताकि वो, और खोल के रखो बॉक्स, उसको देख के भी आपको याद आ जाएगा। ब्लड प्रेशर लेना है, स्टेथ पड़ा हुआ है, टेंडन हैमर नजर आ रही है, टूथपिक नजर आ रहा है, टंग डिप्रेशर नजर आ रहा है, ये सब आपके क्लूज है। एग्जामिनेशन करते हुए तुम्हें याद आ जाएगा। अगर तुम भूल भी रहते, फंडोस्कोप पड़ा हुआ है, ओ यार फंडोस्कोपी नहीं की, क्योंकि उस वक्त स्ट्रेस होगा। यूर ऑल ह्यूमन, आपने अपना 100% देना है, एग्जाम में 70% मार्क पासिंग चाहिए। ओके, सो इट्स ऑल पॉसिबल, हम सब ने किया है। वी आर ऑल लाइक यू, विल नॉट सुपर ह्यूमंस। हमसे बहुत बड़ी गलतियां हुई हैं, एग्जाम में भी गलतियां हुई थी, लेकिन एज फॉरक सेड, मेजर ब्लंडर्स नहीं होने चाहिए, एंड you should be able to defend what you say. Okay.
Thank you so much, sir. I guess it's the Friday, so we need to finish it.
Exactly.
It's already the most time. So thanks to everyone, especially listening to us. You might be thinking कि बहुत सारी फजूल चीजें बता रहे हैं हमें, but I hope somehow these things will help you in your exam and in the longer version of your journey in neurosurgery as well. So thank you everyone. And tomorrow, inshallah, we'll start at 10 a.m. I will have a few things to talk about early in the morning, and then we will start like in 15 or 20 minutes time. We will start with the talks, and I have so many things to share with you. I mean, like cases banana, talks cases banana is not a difficult thing for me. ठीक है, I have been doing it for like 5-6 years now. ठीक है, ये जो अभी आपने जो केसेस देखे हैं, दो I had 5-6 other cases as well. ये रात में आधे घंटे में बैठ के बनाए, ठीक है? So it's not a difficult thing to make new cases or new जो भी चीजें हैं ना, वो इतना मुश्किल नहीं है. But the thing is कि you have to be there, you have to appear and attend these cases. Otherwise कोई मकसद नहीं है, ठीक है? मुझे एफर्ट करने में कोई बुराई नहीं है, कोई मसला नहीं है, ठीक है? But you need to understand that I have my own life as well. I have to do the clinics, I have to do the surgeries. मेरी अपनी रूटीन है. अगर उस रूटीन के बावजूद इफ आई एम ट्राइंग टू हेल्प यू गाइस, सो यू नीड टू बी देयर एज वेल. ठीक है ना, आपको भी उसमें पार्टिसिपेट करना पड़ेगा, अदरवाइज कोई मकसद नहीं है. जनरली वी यूज्ड टू डू दिस सेशंस फॉर लाइक 2 days, maximum 3 days, but now I made it 5 days just for you to have the maximum of the experience of this course. So please be ready for that. Okay, good luck, and inshallah we will see you tomorrow. Take care.